Ma'am, good to go. Control is yours. Ma'am, good to start.
Okay. Hello, everyone. Good evening. All good? Audio fine? Video fine? Audio fine? Video fine?
Ma'am, please screenshot.
Audio
Go.
fine? Video fine?
Ma'am, please screenshot.
Good evening. So, all set for your exam. We've got our session on a good day. Exactly 1 month to go for the exam. How is your preparation going on? I like the date also today. Whenever I'm writing the date today, the date is a good date. Have you all written it down? 12.12.24. So a good date today to do the dermatology session. Yes, 12.12.24. Okay, that's a better way to write. Just don't write 24. It's 12.12. कुछ याद नहीं है. That's a common thing that we hear from the students, especially as the exam is approaching, that they don't remember. But I'll tell you, reading is important, revising is important. You will automatically recall it in the exam से 1 minute पहले भी लगेगा कुछ नहीं आता. You will think you don't remember anything, but trust me, your seniors will tell you, everyone will tell you that exam में सब कुछ याद आ जाता है अगर आपने ठीक से पढ़ा हुआ है. Okay, तो आप बस पढ़ो. You do your work. You don't bother about the outcome. कर्म कर, फल की इच्छा मत कर. बस पढ़ते रहो. Keep studying. You only have to do what is in your hand. In your hand, it is only to study. It is only to revise. You really cannot control your memory. You cannot really predict how much you will remember and what you will not remember. Okay, so don't worry. Just keep studying as much as you can in this last 1 month, because what you study in this last 1 month is going to be the most important for your exam. And this RR session is more than sufficient for revision of dermatology. If somebody has not studied dermatology even once, this is a concise part. There are not much concepts that are going to be discussed today. So maybe, if possible, you can go on our DocTutorials app, see the rapid revision on the app. That is about 7 to 8 hours. So once you watch the 7 to 8 hours of rapid revision on the DocTutorials app, after that you come and watch this session. This is going to be a 2 to 3 hour session. So watch that 7 to 8 hours, then watch this 2 to 3 hours. It'll be sufficient. If you don't have time to even go and watch those 7-8 hours, then I will not agree to that, because I will want you to take out that much time. One short subject demands at least 7 to 8 hours of preparation. Okay, and PYQs in the last 1 month are sufficient. They are sufficient if you have the concepts. Do not just rely on doing PYQs. If you don't have enough time to make concepts, then read the PYQs, read the topics of the PYQs, so that you have something that is better than nothing. So if you are just relying on the PYQs, do it PYTs, previous year topics, not just questions. Okay, your last 3 or 4 papers have given enough proof that one-liners are not going to be sufficient. Only doing PYQs is not going to be sufficient. They are asking questions from within the text. The question paper has moved from just images to now description of the diseases, description of the clinical scenarios. So that actually requires a little bit of in-depth studying. It cannot be done with just one-liner or that all subject revision books. No. Whatever time you have, whatever you are studying, try to study it well. Don't rely on one-liners. Okay? So let's start. First of all, lines in dermatology. And one thing I'll tell you all before we start this session, I will be speaking more, writing less. It will be a quick, rapid revision so that we can finish a major amount of subject soon. It is not going to involve a lot of writing. So all of you also keep your pens down, just listen to it. This is more for listening and a visual recall. Whatever you have your notes in front of you, mark the important points in those notes. Don't write, just mark in your notes what I'm telling you is important today and keep hearing. Okay, I'll also be only speaking, not writing. You also don't write. So starting with the first thing here, lines in dermatology. This has been a very favorite of the INI as well as the FMGE exam. There are 3 important lines in dermatology that we need to know: the Blaschkoid lines, dermatomes, and the Langer's lines. If you get an image of the Blaschkoid lines, how do you identify? You identify by looking at the scalp. When there are spiral lines on the scalp, this is an image of Blaschkoid lines. As simple as that. Okay, spiral lines on the scalp, this is Blaschkoid lines. Overall, if you want to see, there will always be a midline demarcation in these lines, and shape will be different on different body areas. So these are Blaschkoid lines. These are lines of embryonal development. They do not correspond to any nerves, lymphatics, blood vessels, arteries, veins, etc. These are lines at which the embryo, the keratinocytes migrated during the embryogenesis. The different diseases that can happen along the Blaschkoid lines: epidermal nevi, incontinentia pigmentae, hypomelanosis of Ito. In incontinentia pigmentae, I'll show you black lines in Blaschkoid pattern, hypomelanosis of Ito, white lines in Blaschkoid pattern. Okay, so this is how you identify Blaschkoid lines. Then we come to dermatomes. Dermatomes are the lines that correspond to the nerves. These lines are straight lines everywhere on the body. Wherever you see, there will be a midline demarcation, but these lines will be straight everywhere on the body. Can you tell me one disease that happens along the dermatomes? One disease that you need to remember along the dermatomes is herpes zoster, and a very favorite of the INI, segmental vitiligo. So segmental vitiligo and herpes zoster are 2 diseases. No, not HSV, Dr. RG. It is not HSV, it is herpes zoster. They are both very different from each other. It is important to make mistakes now so that you don't make them in the exam. Okay, so herpes zoster happens along the Blaschkoid lines. Segmental vitiligo happens along the Blaschkoid lines. Next, we come to the Langer's lines. This was actually the image that was asked in the INI May 23. They gave this image and asked, what are these lines? These are Langer's lines, also called as relaxed skin tension lines. These are the lines along which the collagen fibers are oriented. How will you identify them? Looking in the exam, you will look at the neck. In the neck, you see a V-shaped necklace. These are Langer's lines. Look at the image here closely. So this is a V-shaped necklace in the neck. These are Langer's lines. If you see the whole picture, it looks like an Egyptian mummy wrapped in bandages. Otherwise, look at the neck. This is a V-shaped necklace on the neck. How do you do a surgical incision? Surgical incisions are given parallel to these Langer's lines. Incisions are given parallel. That is the clinical importance of these Langer's lines. Okay, so these 3 lines for Blaschkoid lines, look at the scalp, spiral. For Langer's lines, look at the necklace. Dermatomes will be straight lines. Pretty simple here. Just let me put this iPad on charge. We don't want it to conk off. Yes. So these are the blascoid lines and dermatomes. Now, next we move to appendigeal disorders. Very, very, very important topic. Every exam, at least one question from here, one question from the sweat or the sebaceous glands. This is a very favorite. And I'll tell you, when you're revising for the FMG exams, you're doing the PYQs. Also make sure that you do the NEET PG and the INI PYQs. You look at the NEET PG 2024 exam and look at the FMG July 24 exam. There are so many questions which are similar to each other. You look at the INIs, there are so many questions which are similar to the ones asked in FMG. It is the same group of people who are making these questions. So when you are revising, you got time, just do the last 3 to 4 years of PYQs of NEET and INI. It is going to help you a lot in the exam. So coming to appendigeal disorders of hair, the disorder that we begin with is alopecia, which is loss of hair. Alopecia can be classified into non-scarring and scarring. Non-scarring is temporary, shows regrowth. Scarring does not show regrowth. Scarring alopecias are also called as cicatricial alopecia. Now, this is a list of non-scarring alopecias, very important. All of them are important. All of them are asked in the exam. An image of moth-eaten alopecia was asked in the NEET PG exam 2024 this time. So for the first time, they gave an image of moth-eaten alopecia also in the exam. These are all very important. Remember it by the mnemonic treats. Treats, trichotillomania, areata, effluvium, androgenetic alopecia, tinea capitis, secondary syphilis shows moth-eaten alopecia, and SLE, which is also a cause of non-scarring alopecia. So if you remember this particular mnemonic treats, you are through with your list of non-scarring alopecias. You can solve every question that comes on this classification, because apart from this, every other alopecia that you read will be scarring. Okay, so apart from treats, every other alopecia that you read, difficult names, long names, they will all be scarring alopecia. So treats. Now, starting with the first one, the non-scarring alopecias. Before we move, this is a simple way how to identify the alopecias in your exam. If a question comes, if a question says patient has had a slow progressing alopecia, which is progressing in a specific pattern. There is hair loss on specific parts of the scalp. Then your answer is going to be androgenetic alopecia. You don't have to think of anything else. It is going to be slowly progressing in a specific pattern. This is androgenetic alopecia. If the question says there is diffuse hair loss all over the scalp, then your answer is going to be the effluviums. It can be anagen effluvium, telogen effluvium. I'll tell you how to differentiate. Diffuse hair fall all over the scalp, effluviums. However, if the question says there are patches of alopecia, then you have to choose between these three. So first of all, in the question on alopecia, find out where is the hair loss. Then you can narrow down your options and mark the correct answer. Okay, so patterned, diffuse, and patchy alopecias. So this is the patterned alopecia, which is androgenetic alopecia. Hormone responsible, 5-DHT. The enzyme which converts it, 5-alpha reductase. So these are the two one-liners that can be asked from here. What is the hormone? Hormone is DHT. And what is the enzyme? This enzyme converts testosterone to dihydrotestosterone, which causes the hair fall. If you get a picture in the men, you will see that there is hair loss starting in the frontotemporal area. So if you get this kind of an image where there is a specific hair fall in the frontotemporal areas, it can also be on the vertex here, then this is an image of androgenetic alopecia. They generally don't give an image of the females because it is very difficult to identify hair fall starting in the midline. So don't worry about this image. The only image from here that they can give in the exam is that of male pattern hair loss. How do you treat? Minoxidil, which is a potassium channel opener, 5% in men, 2% in women. Oral drug, 5-alpha reductase inhibitors, very important question. Finasteride, dutasteride. Finasteride here is given at a dose of 1 mg daily. Can anyone tell me where is 5 mg daily given? Where is 5 mg daily given? Can you tell me where else is finasteride used? We use it at a higher dose of 5 mg daily. Where? Yes, very good. This is used in benign prostatic hyperplasia. So 1 mg is used in androgenetic alopecia and 5 mg is used in BPH. You have to remember this. Next, we come to the effluviums. Effluviums can be of two types, anagen effluvium, telogen effluvium. When a question says patient has cancer chemotherapy and sudden severe hair fall, close your eyes, mark the answer as anagen effluvium. The keyword that you have to catch here is cancer chemotherapy. Patient with cancer chemotherapy, anagen effluvium. Patient with any other trigger with a gap of 3 to 4 months between the hair loss and the trigger, your answer is telogen effluvium. So first of all, in the exam, catch this word that there is diffuse hair loss. If there is diffuse hair loss in a cancer patient, anagen effluvium. Diffuse hair loss in a lady who has just given birth to a baby, or somebody has had COVID, dengue, or typhoid, that is an acute illness, or a surgery. So whenever there is a history of such a trigger, hair loss starts 3 to 4 months after the trigger, the answer is telogen effluvium. They are both self-limiting conditions. They don't require any treatment. So there is no treatment required in both anagen and telogen effluvium. Is that clear? The keywords here and the gap here will take you to the correct answer. Then we have alopecia areata. Alopecia areata is an autoimmune disease mediated by T cells, where the autoimmune cells come to the scalp, they kill the black hair, but they spare the gray hair. So you have to remember that in alopecia areata, gray hair are spared. Okay, and what you get are patches of alopecia on the scalp. So this is very important to see that there will be well-defined patch of alopecia with a clean, smooth, bald skin in it. Very important. The skin inside it is clean and bald. Like I call it in Hindi, chikni chameli. So the skin in the patch is chikni chameli. It is completely clean. You don't see any redness. You don't see any broken hair. It is as if no hair ever were present on this patch. So remember chikni chameli, remember alopecia areata. There can be one patch, there can be multiple patches. Your only thing is to look for chikni chameli. If it is that, this is alopecia areata. Then this image has been asked multiple times in your exam, last being in the June 2021 exam. What is this image? This is the image of exclamation mark hair. So where you see the hair is coming out, it is thin. Towards the end, it is thicker. So this is alopecia areata, exclamation mark hair. Very, very, very important images, all of them. And then this is an image of the nail. What is the most important finding in the nail? Pitting. Pitting means small gaddhe in the nail. So this is pitting. Very important to remember the type of pitting in alopecia areata. Suffer, SFR. Superficial, fine, regular pitting. So you look at this nail, the pitting is superficial, fine, and regular pitting. This nail is also called as geometric nail. So chikni chameli, exclamation mark hair, and geometric pitting. These are the three things that you have to remember about alopecia areata. Treatment of choice, intralesional steroid injection. The steroid that we use here is triamcinolone. Okay, so this is with areata. Next, we move to trichotillomania. Of late, this has become a very favorite of the FMGE exam. This is a psychiatric disorder classified as an obsessive compulsive disorder where the patient pulls out their own hair. So if they pull out their own hair, it is not going to be chikni chameli. They will pull some hair, they will break some hair. So this is going to be a dirty picture here. Okay, bizarre, irregular shape, broken hair. Some areas will show perifollicular hemorrhages. It is a very dirty picture. Okay, so chikni chameli in alopecia areata, remember Katrina Kaif. Dirty picture, that is Vidya Balan, remember in trichotillomania. When you look at this close up also, you see broken hair, dirty picture. So this is not the clean, smooth skin that you were seeing in alopecia areata. Treatment of choice, cognitive behavior therapy. If you have to give medicines, drug of choice, SSRIs. Clear? So irregular margins, perifollicular hemorrhages, broken hair. That is what you have to remember in trichotillomania. And this is another picture of trichotillomania. Again, see this picture. You see the bizarre pattern, irregular shape. You see these broken hair on the scalp. This is how trichotillomania looks like. Isn't it very different from areata? I'm sure you can differentiate. Now, these patients are psychiatric patients. They can sometimes eat the hair, which is called as trichophagia, which can accumulate in the stomach, leading to formation of trichobazoar. Question asked in July 2023 FMGE exam. So what is a complication that can arise out of trichotillomania? Trichobazoar. This is a stone-like concretion made of hair. Next, we come to tinea capitis, that is fungal infection of the hair. Remember, tinea capitis will always be in a child. So if you get a patient who is a child with hair loss on the scalp, look for features of tinea capitis. And whenever there is a fungal infection, there will be scaling, there will be pustules, vesicles, there may be itching. So signs of fungal infection, if present, again take you towards tinea capitis. There are non-inflammatory variants, gray patch, black dot. Inflammatory will be Favus and Kirion. Now, coming to the gray patch type of variant, gray patch, remember the mnemonic GMC. You look at this picture here, you see this gray colored scaling. This gray colored scaling takes you to gray patch. If they ask you what is the organism that causes it, microsporum. What is the type of infection? Ectothrix. Ectothrix means spores are outside the hair shaft. So GMC. Okay, GMC, gray patch, microsporum, ectothrix. Then we have black dot. Here you have to remember the mnemonic BNT. What is BNT? Black dots. Look at this picture here. When you see this kind of hair loss, you see these multiple black dots in the patch. That is why it is called as black dot tinea capitis. These black dots are not seen in alopecia areata. Alopecia areata was chikni chameli. So that is how you differentiate this from alopecia areata. What do I use for tinea capitis? For tinea capitis, I use chiller party. So whenever there is a child patient, you have to think of tinea capitis. So chikni chameli, dirty picture, chiller party. These are the three that you have to remember with respect to the alopecias. Now coming back to BNT, N is for endothrix, T is for trichophyton. Look at this picture here. The spores are present within the hair shaft. So this is an endothrix type of infection. Another point to remember in GMC, Woods lamp positive. The color that we see in Woods lamp is pale green. So if you get an image of Woods lamp of the hair, which is green in color, this is tinea capitis. GMC, BNT. Favus, the only thing you have to remember in Favus is the organism that causes it, Trichophyton schondloni. This question has been asked in NEET PG 21. What is the causative organism of Favus? Just remember, Trichophyton schondloni. Kirion, very, very, very favorite. Again, it will be a child with a red swelling on the scalp. You will see pustules, alopecia. Question may mention regional lymphadenopathy, that is cervical or occipital lymph nodes. This is Kirion. There may be history of pets in the home. That is why I've put a picture of animals here. So a child with a red swelling, with pustules, with alopecia, this is chorion. How do you differentiate chorion from pyoderma? How do you differentiate a chorion from pyoderma? This also looks red. This also has pustules, pyoderma. It is also swollen. So how will you differentiate this? Come on, tell me. How to differentiate a chorion from a pyoderma? Pus is present in both. Pus is present in both, red swelling in both. Why is this not a furuncle? Why is this not a pyoderma? If they ask you what is the next investigation, you can mark a gram stain also if you think of it as a pyoderma. How will you come to the conclusion that it's a chorion? Number one thing, chorion is not painful. Despite all the redness and the pus, the child will happily walk into your clinic. It is not painful. They will let you examine, they will let you look for easy pluckability. This is not painful. Pyoderma is very painful. Plus, the question will say it has been present for 2 to 3 months. How can a child have a pyoderma for 2 to 3 months? Here, there is a short history of 2 to 3 days. Okay, so this is how you differentiate a chorion from a pyoderma. When it is a chorion, next investigation is KOH scraping. When it is pyoderma, then it is gram stain. So you have to know how to differentiate between a chorion and a pyoderma. This is an INI question. This is a NEET PG question. Very, very important. When you do KOH, you see these hyphae. Woods lamp, I already told you, green fluorescence. Only oral treatment, drug of choice, griseofulvin. So do not mark any shampoos, lotions, creams in the treatment of tinea capitis. We only give oral tablets. That is griseofulvin. Double sound coming. Anybody else feeling double sound coming? Is there anybody else who's having an issue? Okay, okay. I have muted the audio from this device. Now let me know if it is better. Okay. So coming back to tinea capitis, drug of choice is griseofulvin. No cream lotions to be marked. That's for sure. Okay. Now we come to the cicatricial alopecias. Cicatricial alopecias don't have to remember the list. Okay. You don't have to remember whatever name you don't understand, whatever is a long name, whatever is not treats is cicatricial alopecia. As simple as that. Okay, don't get worried looking at these names. Now, starting with the important cicatricial alopecias, we have lichen planopilaris, which is lichen planus of the hair. So if there is a question saying violaceous patch of scarring alopecia, wherever the word violaceous comes, you have to think of lichen planus. If there is violaceous color on the scalp, this is lichen planopilaris. They don't give images of this, so don't worry. Discoid lupus erythematosus, again, they don't give image. Only thing that you have to remember is Kapit-Tak sign. So where is Kapit-Tak sign? That is seen in DLE. Remember, discoid lupus erythematosus, scarring alopecia, systemic lupus erythematosus, that is SLE, non-scarring alopecia. Okay, so this is a major difference that you have to remember. Then pseudopallard of Brock has a sign, footprints in the snow pattern. So the two signs that you have to remember, footprints in the snow, pseudopallard, Kapit-Tak sign, discoid lupus erythematosus. Basic. Now we come to traction alopecia. This image used to be a favorite sometime back in your FMG exam. Traction alopecia, traction means pull. So when somebody makes a tight ponytail, you see in the image that there is a tight ponytail and there is hair loss in the front. This is traction alopecia. If a question is asking you to diagnose traction alopecia, it is going to give you a tight ponytail. So ponytail takes you to traction alopecia. Then we come to morphia. A question on morphia was asked in the NEET PG 2024. Just remember, what is the biopsy seen here? A box-like biopsy. So in morphia, what we see is a box-like biopsy. Okay, now when it is on the skin, goes to the scalp, there is going to be scarring on the skin, scarring on the scalp. This is called as linear morphia. It looks as if somebody has hit the head with a sword. So remember Ghajni. If you remember Ghajni, you remember linear morphia, also called as in Coupe de Savre. I hope the alopecias are clear. One question every year is asked from the alopecias. Ghajni is morphia, period. Box-like biopsy. Next, we come to the glands. A question on the glands was asked in the NEET PG 2024. They gave an image. They asked to label the image. So when you get this kind of an image, how do you identify? When there is a gland which is opening directly into the skin, this gland is a VIP gland. It has a special function of sweating and thermoregulation. So this gets a separate opening in the body. This is called as the eccrine sweat gland. So the gland that opens into the skin is eccrine sweat gland. Now there are two glands which open into the hair follicle. There are two glands which open into the hair follicle. The one that opens on the top is the apocrine gland. Like, see, this is the apocrine gland. See the duct. The duct is opening above this chotu gland. This chotu gland is the sebaceous gland. So below is sebaceous gland. Above it is the apocrine gland. This is the marking that you have to remember. This is a very basic image. You see it all the time you study the glands. But when it comes in the exam, there can be a confusion between apocrine and sebaceous gland. The chotu gland is the sebaceous gland. And this bigger gland with the duct that opens on the top, this is the apocrine gland. Okay? Yeah. Now, next we come to the disorders of the glands. The disorder that is important for the FMG exam, Foxford-Dicey disease. This used to be a favorite in 2010 to 20. But now they have not asked in the last few years. They are coming back to their older questions. You know, in the exam now, they're coming back to those questions which they used to ask a little before 2020. So Foxford-Dicey can be a probable question. This is also called as apocrine malaria. Happens due to blockade of the apocrine gland. Apocrine glands are only found in ANG. So this disease is also going to be found only in ANG. Can you tell me what is ANG? What is ANG? Axilla, nipple, and groin. These are the areas where the apocrine glands are found. Plus, these glands are androgen dependent. So the diseases that happen due to these glands will happen after puberty. More than 90% of the patients are females. Presents with itchy skin-colored papules in the axilla, nipple, and the groin. So if you get an image, the image is going to be that of the axilla, where you see skin-colored papules. Okay, this is Foxford-Dicey disease. Then we have hidradenitis suppurativa due to blockade of apocrine as well as hair follicles. This will also happen in ANG, also called as inverse acne. When you look at the image, in the image you will see nodules, abscesses, sinuses, and scarring in the axillary, nipple, and the groin. Okay, so in Foxford-Dicey disease, skin-colored papules. In hidradenitis suppurativa, you see big red pus-filled abscesses. Can you differentiate between these two? Foxford-Dicey, see, skin-colored papules, and hidradenitis suppurativa, you see these pus-filled nodules and abscesses in the axillae. They're both very different from each other, but the image that is generally asked is of the axillae, so you have to know how to differentiate. They also ask what is inverse acne. Inverse acne is hidradenitis suppurativa. Next, we come to Fordyce spots. What are Fordyce spots? Who will tell me? What are Fordyce spots? What is Fordyce spots? Yellow spots. Yes, they're definitely yellow. They're on the lips. But what are they? These are ectopic sebaceous glands. Sebum is yellow in color, so these spots are also yellow in color. Where you see yellow dots on the lips, this is Fordyce spots. Now, this is Fordyce spots, and we just read Fox Fordyce disease. Don't confuse between them. Fox Fordyce disease is a disorder of the apocrine glands, while Fordyce spots are sebaceous glands. How will you remember? Remember S. S in seb, S in Fordyce spots. So these are ectopic sebaceous glands, Fordyce spots. This is very different from Fox Fordyce disease, which is due to apocrine blockade. Now, these Fox Fordyce spots, if you get in the image you see yellow, yellow, yellow dots on the lips. These are Fordyce spots. These are ectopic sebaceous glands, an anatomical variant, not a disease. No treatment is required. Fordyce spots. Then we come to acne vulgaris, which is a disorder of pilosebaceous unit. Very important to remember. What is the meaning of pilosebaceous unit? Both hair and sebaceous glands are involved. So never mark acne as just a disorder of the sebaceous gland. This is a disorder of both hair and sebaceous gland. That is pilosebaceous unit. A question on acne has been asked in almost every exam over the last 7 to 8 exams. If I count the exams from 2020 to now, we have had almost 8 exams. In these 8 exams, acne has been asked 7 times. So this is a very, very important topic. What is the primary lesion of acne? Primary lesion happens due to blockade of the hair follicle. Primary lesion is a comedon. So primary lesion of acne is a comedon. Then they have asked, what is the bacteria that is responsible in pathogenesis of acne? Propionibacterium acnes. Sebum increases or decreases? It increases. So everything is increasing in acne. Blockade increasing, sebum increasing, bacteria increasing, inflammation increasing. Here the questions they ask: disorder of pilosebaceous unit, primary lesion, that's a comedon, bacteria, P. acnes. What happens to the sebum? That increases. Okay, so all these points of pathogenesis are important. Clinically, the primary lesion, that is comedon, how does it look like? Comedon looks like these black points on the skin. So it will be raised like this, and it will have a black dot on the top. Look at this image. These are all comedons. You may have seen that in your face, in your friend's face. The blackheads that we call, these are all comedons. Then they have asked, what is the treatment of choice for comedonal acne? Topical retinoids. What are the topical retinoids that we use? Tretinoin and adapalene. So topical retinoids, tretinoin, adapalene. What we never use in acne, not used in acne, are topical steroids. This is a question that has been asked in the INI November 21. They gave an image of comedonal acne. They asked what is not used. Not used is topical steroids. Then this is a very favorite image. This is an image of nodulocystic acne. You see these big nodulocystic lesions. There are pustules here, there are comedons, there are papules. So there are all stages of disease present at the same time. That is why acne is known to have pleomorphic lesions. Acne has pleomorphic lesions. Which other disease has pleomorphic lesions? That is all stages of the disease present at the same time. There are only two diseases in dermatology with pleomorphic lesions. One is acne and the other is yes, very good. The correct answer is varicella or chickenpox. Two times that you have to remember: pleomorphic, acne, and varicella. So this is nodulocystic lesion. A similar image was given in your July 23 exam. They gave this image and they asked, what is the primary lesion of the disease? So even if they give an image in which you see a lot of nodulocystic lesions, you may see a lot of pustules, identify the diagnosis of acne and mark comedon as the primary lesion. Please don't mark nodules or pustules or papules as the primary lesion. This was a mistake done by a lot of students in that exam. Primary lesion of acne is always going to be a comedon. Then what is the most severe type? Nodulocystic. Treatment of choice for nodulocystic acne? Isotretinoin. What is the best treatment for acne? Isotretinoin. This was a question asked in the NEET PG 2024. They gave an image of acne and they asked what is the best treatment for this patient. So best treatment is isotretinoin. Please remember, don't mark antibiotics here. Best is always isotretinoin. Now, isotretinoin is given at a dose of 1 mg per kg per day. Total cumulative dose of 120 to 150 mg per kg. Again, this has been asked in your exam. Most important side effect, teratogenicity, has been asked multiple times in the exam. So most important side effect of isotretinoin is teratogenicity. Patient has to have a UPT negative gap of at least 1 month between stopping the drug and planning the pregnancy. What are other side effects of isotretinoin that are common to all oral retinoids? You may have read that in pharma. It increases triglyceride levels. It increases the liver enzymes. So it causes deranged LFTs and hypertriglyceridemia. These are the other side effects of oral retinoids. Now, this was a question that was asked in the NEET 23, hormonal acne. If a woman has hirsutism, that is hair in the hormonal area which are dark black, with acne in this hormonal area, with infertility, irregular menses, obesity, either of these factors, it hints towards hormonal acne. Maybe the patient is suffering from PCOS. So in such a patient, you have to evaluate for hormonal imbalance. What is the hormonal imbalance? Hyperandrogenism. This was the correct answer in the question. If you get a patient with hormonal acne, evaluate for hyperandrogens, treatment with cyproterone. Okay, this is hormonal acne. Look at the dark black hair here. This is hirsutism and severe acne which is not responding to routine treatments. Then we have rosacea. Rosacea will be a female with burning sensation on the face that increases with sun exposure, increases with drinking coffee. You see redness, papules, pustules on the face. But how do you differentiate it from acne? When you look at this kind of picture, you can very well call it a picture of acne also. This is how our patients were with acne come. And this is a sign that I use clinically also. How to differentiate acne from rosacea. Yes, very important. There are no comedons here. No comedons in rosacea. Okay. Plus, there will be a history of increased burning with sun, with tea or coffee. So when such kind of history is present, then you have to think of rosacea. Look at this. In rosacea, the tip of the nose is involved, the cheeks can be involved, the chin can be involved. This spares the creases. That is another difference from acne. So no comedons, no creases. These are two negative things that you have to remember with rosacea. Now, sometimes in the exam, you also get a question how to differentiate rosacea from the other picture. Can anyone tell me what is the other picture showing? This is a very common doubt for a lot of students. What is the second picture showing? Yes, this is an image of SLE, that is the malar rash. How do you differentiate between rosacea and SLE? In rosacea, it is the tip of the nose that is involved. In SLE, it is the bridge that is involved. Okay, so in SLE, you have to see the bridge. The redness comes from the malar area over to the bridge, crosses to the other area. So this is a rash which is called as the butterfly rash. Secondly, in the exam, patient may be having fever, joint pains, photosensitivity. So if this kind of a history of systemic involvement of fever, joint pain is given, then they're further taking you towards SLE. This is the difference between rosacea and SLE. Then there is another thing which is there in the options, melasma. Melasma is also present on both cheeks, but it is brown in color. So this is absolutely not to be confused with rosacea. It is brown, it is there in the options, but don't mark it. Rosacea versus malar rash should be easy if you just look at the tip of the nose. Then if rosacea is not treated, it stays for a long time. Patient can develop rhinophyma, also called as potato nose. So this is an important question that you have to remember. Long-standing rosacea can lead to rhinophyma. So with this, we finish appendages and the disorders. That is almost 1 to 2 questions of your exam that was catered with that. But I'll tell you, even more important are the infections, the bacterial, viral, fungal, even leprosy. They have recently become very fond of STDs. These are extremely favorite of the examiners because एक तीर से चार निशाने हो जाते हैं. They ask you questions related to microbiology, dermatology, sometimes PSM, medicine. So with one question, they can actually cover 4 subjects, which is like a win-win situation for them. So infections are a very, very, very important thing that you have to remember. Now, coming to the bacterial infections, impetigo. Impetigo is of 2 types, non-bullous impetigo, bullous impetigo. Impetigos में जब आपको ये golden yellow honey colored crusting दिखेगी, this is non-bullous impetigo, caused by strep pyogenes, honey colored crusting, a complication post streptococcal glomerulonephritis. So in the August 2020 exam, they gave an image of impetigo. They ask you what is the possible complication. So complication is PSGN. Please remember, it does not cause acute rheumatic fever. Skin infections with streptococcus do not cause acute rheumatic fever. You only have to mark PSGN there. Okay, so that is one important point that you have to remember. Then we come to bullous impetigo. इसमें आपको बुला दिखेगा with pus. This is caused by Staph aureus. So non-bullous impetigo, streptococcus, bullous impetigo, Staph aureus. Basic, simple. Now, before I move forward, who will tell me what is the type of hypersensitivity in PSGN? What is the type of hypersensitivity in PSGN? Very good. This is a type 3 HS. So this is a type 3 hypersensitivity. Then we have erysipelas. Erysipelas are caused by streptococcus, infection of the dermal lymphatics. You get a red plaque with a definite margin. So here you have been asked what causes erysipelas. This is streptococcus, infection of lymphatics. Cellulitis is infection of the fat. Fat has no boundaries. When we gain fat in all directions. So when you have cellulitis, cellulitis also goes and spreads in all directions. This is a loosely defined swelling without any boundaries. So erysipelas has a margin. Cellulitis does not have any margin. This is the difference between these two. So erysipelas, strep, lymphatic, cellulitis is fat. Then we have staphylococcal scalded skin syndrome. यहाँ पे history होगी baby with a localized infection. Generally, they give history of otitis externa. So there is a baby with otitis externa. That baby develops peeling of skin all over the body. No mucosal involvement. What is the diagnosis? Diagnosis is staphylococcal scalded skin syndrome. So simple है, baby with infection, with peeling. This is staphylococcal scalded skin syndrome. But sometimes in the exam, what they do is they tell you that baby has infection After this baby has been given antibiotics, now there is peeling of skin. So, how do you choose between staphylococcal scalded skin syndrome and a drug rash? Drug rash also has peeling of skin. So, tell me, how do you differentiate between these two? Yes. How do you differentiate? How do you differentiate? Trunk is not important here. Peeling of skin to dono mein hogi. You look for the mucosa. If there is no mucosal involvement, this is S4. If oral ulcers are written, there is mucosal involvement, then this is a drug rash. This is how you differentiate between these two. This question has been asked in the NEET exam 2019. So it is important to know, look for mucosal involvement. With mucosa, it is going to be a drug rash because, as is mentioned here, there is no mucosal involvement in S4. They can sometimes ask you the name of the toxin, epidermolytic toxin, target of the toxin, desmogreen 1. And if they give an image, in the image you see that the baby has peeling of skin over the entire body. Then, coming to follicular pyodermas, they can give an image of furuncle. In furuncle, you will see a big red nodule with pus point in it. Furuncle in that exam was written as follicular abscess. So another name for furuncle is follicular abscess. You see a big red nodule with pus pointers. Carbuncle, they have not asked for a while, but you should still remember, seen in a patient who is diabetic with high sugars. Most common site is the neck. You see a big red painful lesion with multiple pustules and sinuses on it. Carbuncle. So for them to make a diagnosis of carbuncle, they will tell you that the patient is a diabetic with uncontrolled sugars. That is how you differentiate between a furuncle and a carbuncle. Paronychia, you see an image of the nail fold. In the nail fold, there will be redness, pus, and swelling. This is acute paronychia. A for acute, A for aureus. So Staph aureus is the most common cause of acute paronychia. Treatment of choice for staph infections, antibiotics. Which antibiotics? Amoxiclav. Like they gave a question in the NEET PG 21. They said patient has paronychia, has now developed red painful streak on the arm. What is the treatment? See, the question is telling you that there is paronychia. In paronychia, you have to think of Staph aureus. When you think of Staph aureus, you have to mark amoxiclav. Others were amikacin, ciprofloxacin. You are not going to mark those for Staph aureus. So that is like a question you had to pick up that the patient has paronychia. Even if you get these kind of images, which are new images, which you may not be able to identify, look for hints in the text. They are always there. So this is Staph aureus, mark amoxiclav. Erythrasma, very, very, very important for the FMGE exam. This is caused by Corynebacterium minutissimum, generally seen in diabetics in the skin fold. What you get in the exam is this line, asymptomatic scaly lesion in the axilla. So when there is an asymptomatic is very important because this is non-itchy. So this is an asymptomatic lesion in the axilla. What is the next investigation? Wood's lamp. What is the color that you see in Wood's lamp? Coral red fluorescence. If they give you an image, an asymptomatic hyperpigmented rash, very easy to identify. If they give this image of the underarm, which is red in color, this is coral red fluorescence. Now, when you get lesions in the axillae, scaly lesion. So scaly lesion in the axillae, what is going to be your answer? It could be erythrasma. It could be tinea. It could be flexural psoriasis. How do you differentiate between these? See, erythrasma will always be asymptomatic, non-itchy. Next investigation, Woods lamp. Okay. Tinea will always be itchy, plus there will be redness. Next investigation will be a KOH scraping. If it is flexural psoriasis, it will be a red, well-defined plaque. Next investigation will be a biopsy. So this is how you approach a question which has scaly lesion in the axilla. Mostly you have to differentiate between erythrasma and tinea, in which non-itchy is erythrasma, itchy is tinea. For erythrasma, Woods lamp. For tinea, KOH. Okay, so this is going to be your approach to these questions. Is that understood by everyone? Image, coral red fluorescence, erythrasma. Now we come to mycobacterial infections of the skin. In mycobacterial infections, TBVC on its own, TBVC is not asked, but it is a DD of subcutaneous mycosis. So in a lot of those questions, you may see TBVC written. Now, TBVC is also seen in a farmer. It is also seen in the foot. That is why it is a DD of subcutaneous mycosis. But this will generally just be a single small lesion with a rough surface. So this will be a single small lesion with a rough surface. This is TBVC. On its own, they don't ask, but for the options, you have to rule it out. Single lesion with a rough surface in a farmer on the foot. Tuberculosis, verrucosa, cutis. When we have lupus vulgaris, what are mycobacterial infections? Like TB causes mycobacterial infections of the lung. TB can sometimes come on the skin. That bacteria can cause skin infections. So these are mycobacterial skin infections. TBVC was seen in a farmer. Lupus vulgaris can be seen in anyone. This is the most common cutaneous TB in adults in India. This was a question in your January 24 exam. This will be an annular lesion, fleshy, reddish brown in color. The margins are active and there is scarring in the center. So this is the most important point that you have to remember about lupus vulgaris, is that there is scarring in the center. The margins are active. This is how they had asked the question in the January exam. A patient presents with an annular lesion which has active margins and scarring in the center. What is the diagnosis? The diagnosis here is lupus vulgaris. Very, very important. You know, we used to teach this every year because this was a question asked sometime back in 2014-15. Suddenly they have now asked after a good 8-9 years gap. So scarring in the center, active margins, lupus vulgaris. You press the lesion with a glass slide. This is called as diascopy. You see apple jelly nodules here. So when you get an annular lesion in the exam, look at the margins and the center. What are these annular lesions that can be asked? You can be asked a question on lupus vulgaris, leishmaniasis, tinea, and granuloma annulare. How do you differentiate? What will be the margins in lupus vulgaris? Margins in lupus vulgaris will be active, center will show scarring. What will happen in leishmaniasis? Leishmaniasis, margins will show scarring, center will be active. That means there will be an ulcer in the center. In tinea, margins will show scaling, vesicles, pustules, center will show clearing and it will be itchy. What happens in granuloma annulare? Granuloma annulare margins will be skin colored. Center will be normal skin. So this is how you approach a question on annular lesions in dermatology. Differentiate between lupus vulgaris, leishmaniasis, tinea, and granuloma annulare. These were the 4 options in your January exam. This kind of a question, the answer to that was lupus vulgaris. Is that clear to everyone? Can you tell me what is the sign which is seen in leishmaniasis, which has active ulcer and scarring in the margins? What is the sign that we see here? Who will tell me what is the sign? This was also a very commonly asked question in the back previous decade, I will say. What is the sign here in leishmaniasis which you see? Come on, tell me. Come on, come on. I'm waiting for the answer. The sign that we see there is volcano sign. So this is called as the volcano sign. You see, when there is scarring in the center, there is ulcer, but the scarring in the margins and ulcer in the center looks like a volcano. This is called as volcano sign in leishmaniasis. Then granuloma annulare, I told you there will be a skin colored margin with a normal skin in the center. It is not itchy, it has no redness, no scaling. That is how you differentiate it from the others. This is granuloma annulare. While tinea will show scaling, vesicles, redness, it will be extremely itchy, center will show clearing. So these are the 4 annular lesions that you have to differentiate from each other. Next, we have a scrophulodoma, question asked in your August 2020 exam. This is generally seen in children. You will see multiple sinuses in the neck with bluish margins. Whenever there are tubercular ulcers on the skin, they always have bluish margins and undermined edges. So this is common to all tubercular ulcers. You will see this in scrophulodoma also. There will be a child with such multiple discharging sinuses on the neck with violaceous or bluish margins, undermined edges, pus is AFB positive. How does scrophulodoma happen? Direct contiguous spread of infection. They can ask this also. What is the mode of spread to the skin? Mode of spread is direct contiguous spread. Is this clear to everyone? Scrophulodoma is a PYQ. You should be able to identify the image. This they generally only ask erythema nodosum. So this slide is only to tell you how to identify erythema nodosum in the exam. These will be painful red lesions on the shins. So painful red nodules on the shins. This is erythema nodosum. Most commonly, it is caused after streptococcal infections. It can also be seen in tuberculosis. Plus, it can also be seen in sarcoidosis. When it happens in sarcoidosis, it is generally a part of the Lofgren syndrome. Lofgren may, if you remember EN is erythema nodosum. So erythema nodosum, they have not really given an image, but if they give, it is multiple red painful nodules on the leg, on the anterior shin. So this is erythema nodosum. Sarcoidosis, they can ask, it's a part of Lofgren syndrome. Next, we come to leprosy. I know how much you all hate leprosy. I also hated it in the MBBS. I don't like leprosy at all. Even in MBBS, it took me a while to, get used to reading it. In fact, our degrees DVL, dermatology, venereology, and leprology. So we are leprologists. We are supposed to be experts in leprosy. It's a difficult topic for you to understand, but of late, they have started asking leprosy a lot in the exam. So please don't skip it. At least read what I'm telling you now. That is like the bare minimum that you have to know in leprosy. What are the cardinal features? Skin lesion with loss of sensation. Simple question. July 23 exam, patient presents with skin lesion with loss of sensation. What is the diagnosis? Diagnosis is leprosy. Please remember, leprosy is also called as Hansen's disease. So in that exam, they give Hansen's in the option. A lot of students might not have read that leprosy is also called as Hansen's. Please remember, this is important. Then there can be nerve enlargement with peripheral neuropathy. There can be sensory or a motor loss. Bacteria can be present on the skin. Slit skin smear can be positive. So these are the cardinal features of a leprosy patient. Now, according to Ridley-Joplin classification, we have 5 types of leprosy: tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. So there are 5 types. Tuberculoid has the best immunity, single lesion, hypopigmented with loss of sensation. This is like a classic leprosy lesion. It can be given in the image, it can be given in the text, as has been given in your July exam. So please remember, single hypopigmented skin lesion with sensory loss. With borderline tuberculoid, it is the most common type in India. Secondly, it has these special lesions. What are these? Satellite lesions. So with borderline tuberculoid, you have to remember satellite lesions are seen here. With borderline, the only question they ask is annular lesions. So where are ring-shaped lesions? Annular means ring-shaped. So where are ring-shaped lesions seen? These are seen in borderline leprosy. That is why it is also called as annular leprosy. Then there are 2 named signs here. They no longer ask, but if you want to remember inverted cup saucer appearance, Swiss cheese appearance. These are also seen in borderline leprosy. Then we come to borderline lepromatous leprosy, such a favorite of your exams now. This has been asked so many times in the MEET, in the INI, in the FMG, how to differentiate between BL and LL. See, there are multiple lesions with multiple nerve enlargement in both. So in borderline lepromatous as well as lepromatous leprosy, there are multiple lesions on the body. There are multiple nerves that are enlarged. Then how do you differentiate? In BL, it is still not symmetrical. It is tending, means trying to be symmetrical. While in lepromatous leprosy, symmetrical nerves, symmetrical skin lesions, almost the entire skin is involved. Then in BL, there will still be loss of sensation in the lesions. In LL leprosy, there will be no loss of sensation in the leprosy lesions. That's a very important difference that you have to remember. BL will have loss of sensation, LL does not have. What LL has is glove and stocking anesthesia. Plus, this was the question in your Jan 24 exam. SSS positive only from the lesion, negative from normal skin. So if the question says SSS is positive only from the lesion and negative from the normal skin, it is talking about BL leprosy. If it says it is positive in skin as well as the lesion, then it is lepromatous leprosy. This was the concept that was asked in your January exam. I was shocked when I saw that question. I was like, how are they asking in the FMG exam? This has never even been asked in the INI exam. So this is like a tough thing to know. If you have not read, it's very difficult. So please remember, SSS in BL is positive only from the lesion, while in LL the infection is all over the body. So it will be positive from both the skin as well as the lesion. Plus, this is an image that has been given in your December 2020 exam. This is an image of leonine facies, which is seen in LL leprosy. You see there is loss of eyebrows here, madarosis, saddle nose, Buddha ears, and the full leonine facies, the thick, rugged skin. So where is this seen? This is seen in LL. Always in LL, lepromatous leprosy. These are the questions that have been asked from leprosy. Now, histopathology was asked in the NEET PG 24 exam. So we have to know this. when there is a well-defined granuloma in the skin, like you see in this image, a well-defined granuloma here with giant cells, as you can see here. So a well-defined granuloma with giant cells. This is, what leprosy is this? Where do you see well-defined granuloma with giant cells? I have not marked it here. So who will tell me which is which type of leprosy? What is on the right? What is on the left? What type of leprosy is this? What is classic type of leprosy? There is no leprosy which is classic leprosy. Acha, you mean to say the first type that we read? Okay, then I take it. Okay, so this is TT leprosy. Because the immunity is good here, the body is able to form granulomas with giant cells. This is TT leprosy. Here you only see macrophage collection, which have become foamy. Plus you see a clear zone. This is the Gren zone. This is LL leprosy. So the questions that come here, where is well-defined granuloma seen? TT. Where is Gren zone seen? Where a foamy macrophage is seen? This is seen in LL leprosy. If they give you image will only be given of the TT leprosy. Identify the granulomas. If you identify the granulomas, mark the answer as TT leprosy. Most common nerve, ulnar nerve. Most common cranial nerve, facial nerve. Apart from facial nerve, trigeminal nerve can also be involved. First sensation to go, thermal sensation. Wish your exam was full of such one-liners, but no, not anymore. But still, these are some basics that you have to remember. Most common, ulnar. Cranial mein facial and trigeminal both can be involved. First sensation is thermal sensation. The type of leprosy where only nerve involvement, no skin involvement. This is pure neuritic leprosy. Treatment of choice, MBMDT kit. If you get an image, this is a red blister pack. 6 months, PB patients, 12 months, MB patients. What is one side effect that can arise from clofazimine? Reddish brown pigmentation of the skin. This was a question asked in the INI May 2024. Which anti-leprosy drug causes reddish brown pigmentation of the skin? This is caused by clofazimine. So remember this. Remember now there is just one kit, which is the MB kit, 6 months and 12 months. There is no PB kit anymore. Now coming to leprosy reactions. If the leprosy lesion is red and swollen, type 1 reaction. If there are multiple painful nodules all over the body, which is erythema nodosum leprosum, then it is type 2 reaction. You remember I just showed you erythema nodosum, which were red painful nodules on the legs. When such kind of red painful nodules happen in a leprosy patient, this is called as erythema nodosum leprosum. This is type 2, and type 1 will have redness and swelling over the entire lesion. Type 1 will be seen in BT, BB and BL leprosy. Type 2 is only seen in LL leprosy. Treatment, continue the MBMDT. That is the most important point in all the exams, and start steroids. Never ever mark stop MBMDT. Okay, never mark that. Always continue MBMDT with steroids. There is another drug that can be given in type 2, that is thalidomide. So another drug that can be given in type 2 reaction, thalidomide, but it is not the drug of choice. You don't have to mark it. Drug of choice are steroids. Can you tell me one more complication or a side effect of thalidomide? What is the side effect of thalidomide? Batao. Give me a side effect of thalidomide. Yes, focomelia, seal limbs, teratogenicity. सबसे पहले teratogenicity तो बोलो. Yes, teratogenicity. So with this, we finish leprosy. I hope leprosy is clear. I hope you know how to differentiate between BL and LL. Very important. Then annular leprosy was BB. Simple hypopigmented leprosy with loss of sensation is TT. Then there is one more, which is indeterminate leprosy. Indeterminate leprosy seen in a child with a single hypopigmented macule on the face. So indeterminate leprosy is a child with a single hypopigmented macule on the face. No loss of sensation. When you read no loss of sensation, you don't mark it as leprosy. But please remember, in indeterminate leprosy, there is no loss of sensation. There is no scaling. Child is generally a resident of Bihar, Jharkhand, or Chhattisgarh, which are endemic areas for leprosy. Now, can you tell me one DD of indeterminate leprosy? This is also seen in a child. This is also hypopigmented macules. Also on face. What is this? This is P. alba. That is pityriasis alba. So what is the difference? This is also hypopigmented macule on the face, but they are multiple and they have scaling. So that's how you differentiate P. alba from indeterminate leprosy. And sometimes in this list, there is another which is P. versicolor, because this is also hypopigmented macule with scaling. So how do you differentiate? This is present on the upper back and the upper chest. So P. alba will be hypopigmented scaly macules on the face. P. versicolor will be hypopigmented scaly macules on the back or the chest. It is not the same. Okay, please remember, this is not the same. Yes, there can be both hypo and hyperpigmented macules in P. versicolor, but generally in the exam, they give you this kind of an image where hypopigmented scaly macules are seen. They have asked the cause. The cause is Malassezia globosa and Malassezia purpura. These are normal commensals of the skin. They can cause P. versicolor. KOH shows a spaghetti meatball appearance because this is a dimorphic fungus. It shows spaghetti meatball appearance. Wood's lamp, PV shows PY fluorescence. So Wood's lamp, PV shows a PY fluorescence. Drugs used, azoles, ketoconazole, itraconazole, fluconazole. You can use any of that, but it is important to know what cannot be used. Griseofulvin and terbinafine. So in P. versicolor, there is no role of treatment with griseofulvin or terbinafine. You can use all types of azoles, but not these. You can get this image. This is the spaghetti and meatball appearance of P. versicolor. The spaghetti are the hyphae and the meatball are the yeast forms. This is a dimorphic fungus. Then we have oral candidiasis. They can give you an image of oral candidiasis. This is also called as pseudomembranous candidiasis. There is a yellow, there is a white pseudo membrane in the oral cavity. Who will tell me, can this be rubbed off or not rubbed off? Can this be rubbed off or not rubbed off? No, 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 no. Whoever is answering can't be rubbed off. Please remember, this can be rubbed off. This is a very important point to differentiate it from OHL, which is oral hairy leukoplakia, because oral hairy leukoplakia can't be rubbed off. Diphtheria can't be rubbed off. So OHL is generally a DD in an HIV patient. Diphtheria is a DD if it is a child, but it is only candidiasis which can be rubbed off. Very, very important. So this is acute pseudomembranous candidiasis. One question that comes with respect to pharma and medicine is that a patient is a case of bronchial asthma, taking oral inhalers, but he's not taking inhalers. So if he's not inhaling properly, the drug that is a steroid is going into the oral cavity, which predisposes the patient to develop oral candidiasis. So this can be seen in diabetics, it can be seen in HIV, organ transplant patients. It can also be seen in patients who are not taking their steroid inhalers properly. So this is oral candidiasis. Then we come to tinea. Tinea is infection which is caused by the dermatophytes. This will be a red annular plaque with scalings, vesicles, pustules. The most important point that takes you to a diagnosis of tinea is itchy. So this is itchy. Most common cause, trichophyton rubrum. Most common cause, trichophyton rubrum. When it happens in the groin, it is called as dhobi itch or jock itch. When it happens on the foot, this is called as athlete's foot. So when you get this kind of a red annular lesion in the groin, this is tinea cruris. When this is modified by steroids, patient is applying an over-the-counter cream, the itching reduces, but it recurs on stopping the cream. This is tinea incognito. This was your question in the July 23 exam. A patient with itchy lesion in the groin, applying a steroid cream taken from a local chemist. There is improvement as long as he is using the cream, but on stopping the cream, the redness and the itching comes back. What is the diagnosis? This is tinea incognito. Because it is not red so much, doesn't have so much scaling, doesn't have so much itching, so it's difficult to identify when you see this. That is why it is called as tinea incognito. Then we have tinea of the nail, which is called as onychomycosis. You see discoloration of the nail. That is the most important hint to diagnosis of onychomycosis. There may be scaling under the nail, which is called as subungual hyperkeratosis. This image has been asked in your exam in 2021. Scaling under the nail is called as subungual hyperkeratosis. Most important hint to diagnosis, discoloration of the nail. Most common type, DLSO. Now, how do you treat tinnias? Drug of choice for all tinnias is terbinafine, except tinea capitis, where we give griseofulvin. So, except tinea capitis, where we give griseofulvin, for all tinnias, drug of choice is terbinafine. T for tinea, T for terbinafine, you have to remember. For nail tinnias, nail lacquers can be used. Important question has been asked in NEET PG 2020, has been asked in INI November 24. So nail lacquers is important to remember. How do you remember? Tacit. The mnemonic is tacit. Tavabarol, emerolfin, cyclopyrox, econazole, terbinafine. These are the 5 drugs that are used in the form of nail polish. They are applied on the nail like nail polish. That is why it is called as nail lacquer, used in the treatment of onychomycosis. Tacit. Tavabarol, emerolfin, cyclopyrox, econazole, terbinafine. If you have to give oral drugs, give it for 6 weeks daily. In toenails, 12 weeks daily. Pulse therapy done with itoconazole. Kya hoti hai, kyun hoti hai, you don't need to know. Just remember, if a question comes, how much time do you give a daily oral antifungal for fingernail infection? 6 weeks. How long for toenail? 12 weeks. Simple. Moving to the next and the most important topic from fungal infection. Very important. The subcutaneous mycosis. This is like the papa, dada, nana, mama, whatever of the exam. Every exam, there is going to be one question from this. That is the subcutaneous mycosis. It will be on the hand or the foot. Patient is going to be a farmer or a gardener. There will be history of a penetration trauma. So this is your clinical setting. You can either have a question on sporotrichosis or chromoblastomycosis or mycetoma. So how do you tell which is which? In sporotrichosis, suppose lesion is on the leg, lesions will be in a chain. So these will be linear lesions. Like you see in this image also, there will be nodules in a line. Some of them can ulcerate. So this is sporotrichosis. You see a chain or a line. This is sporotrichosis. And more commonly, sporotrichosis is on the upper limb. More commonly, this is on the upper limb. Then we come to chromoblastomycosis. Chromoblastomycosis, you have to remember Gobi. Gobi or Gobi, whatever is the spelling. I don't think this is Gobi, it is Gobi. So this is Gobi. So wherever on the foot you see Gobi, this Gobi is chromoblastomycosis. C for chromoblastomycosis, C for cauliflower, because the surface of the lesions is like cauliflower. Then we come to mycetoma. Mycetoma, the whole foot is going to be swollen. So there is going to be swelling of the whole foot. So if you see a chain, sporotrichosis, Gobi, cauliflower, chromoblastomycosis, full foot is swollen, there are discharging sinuses on it. This is mycetoma. You look at the picture, you will be able to identify if you keep this in mind. See, sporotrichosis, there will be history of the patient being a rose gardener. These nodules will be present in a line. Distribution is lymphoid. The type of involvement is ascending lymphangitis. What you can see are these asteroid bodies or cigar-shaped yeast. Treatment is itraconazole. Like it was asked in your January exam, a patient who is a gardener presents with lesions extending from the hand to the axilla. What is the structure involved? So if it is a gardener with lesions extending from the hand to the axilla, that means it is a chain extending from the hand to the axilla. Structure involved here was lymphangitis. So that was how it was asked in your January exam. No image, nothing. They just asked you the text. So you have to remember the text as well. Don't just rote learn the images. Then another DD of this is the infection caused by M. marinum, which is fish tank granuloma. Here also you see nodules in a chain on the hand, but patient will be a water-related occupation. They may be a swimming pool cleaner, they may be a fish farmer, but the occupation is going to be water. If it is a farmer or a gardener, it is sporotrichosis. If it is water, then it is fish tank granuloma. Now we come to chromoblastomycosis. Chromoblastomycosis, C, C, C. C, chromoblastomycosis. C, cauliflower. You see the Gobi here? This is the cauliflower. That was there in the image also, which I showed previously. And the last C is the copper penny bodies. So you see these copper colored coins in the biopsy. This is chromoblastomycosis. How to remember the names of copper penny bodies? CMS. Copper penny bodies, medlar bodies, sclerotic bodies. These are the other names for these which are seen. Very, very important. Then we have mycetoma. This will be on the foot of a farmer. The entire foot is going to be swollen. There are two types, eumycetoma, actinomycetoma. Eumycetoma is caused by the fungus. Actinomycetoma is caused by the bacteria. If you do a gram stain, this will show gram negative hyphae. If you do this, this will show gram positive filamentous bacteria. You will have read this in micro also. Important to know these gram findings because this has been asked in the recent NEET PG exam. How to differentiate gram negative hyphae takes you to fungus, gram positive filaments take you to actinomycetoma. This image asked multiple times in the FMG exam. Farmer with swelling of the foot, with discharging sinuses and granules. This is mycetoma. Remember, this swelling is painless. This painless firm subcutaneous swelling is also called as tumefaction. So this is tumefaction with sinuses, with pus discharge. Yes, this is also called as Madura foot. Most common cause of eumycetoma, Madurella mycetomatis. Next, we come to viral infections. Viral infections, this was recently your question in the July 24 exam, an image of herpes labialis. So labialis means lips. So when you see these grouped painful vesicles on the lips, this is herpes labialis. Basically, wherever you read the word herpes, herpes is grouped painful vesicles on a red base. So wherever you read the word herpes, that means grouped painful vesicles on red base. When this is on the lips, this is called as herpes labialis. When it is on the genitalia, this is called as herpes genitalis. When this is in a dermatomal distribution, this is herpes zoster. Herpes labialis is caused by herpes simplex virus 1, genitalis, herpes simplex virus 2, herpes zoster, varicella zoster virus. Please don't confuse between this. This is a very important concept. Herpes labialis, herpes genitalis, and herpes zoster. They are not the same. Now, this was the image. Grouped painful vesicles on the lips. Herpes labialis caused by HSV1, site of latency, trigeminal ganglion. With varicella zoster virus, primary infection causes varicella, goes and lies latent in the dorsal nerve root ganglion. Secondary eruption causes herpes zoster. So remember, varicella and zoster are caused by the same virus, which is varicella zoster virus. It is not different viruses causing these two diseases. Then varicella has been a very favorite of your exam, asked twice. I think it was asked even more than what I have written here. Very, very favorite question. How does the question come? Fever with vesicles all over the body in a child. This is varicella. Fever with pleomorphic rash, varicella. Dewdrop on rose petal appearance, varicella. As simple as that. Whenever there is a question which has a vesicular rash, you have to think of varicella. Fever with vesicles all over the body, varicella. Fever with vesicles on hand, foot, and mouth. This is hand, foot, mouth disease. So this is going to be your approach to a patient who has fever with vesicles. You don't have to mark any other disease, roseola, rubella, dengue, measles. None of them have vesicles. So when you read vesicles that are fluid-filled blisters, think of varicella. They have given an image of varicella. They have given image of dewdrops. They have asked fever with pleomorphic rash. Everything has been asked. The distribution of the rash is centripetal. Then we come to herpes zoster, again a very favorite, as recent as a January 23 question, also called as shingles. You get these grouped painful vesicles in a dermatomal distribution. This is herpes zoster. Most common site, thoracic. When you make a Zank smear, the finding in Zank smear for all herpes is multinucleate giant cells. You see these cells with lobulated nucleus? These are MNGs. Treatment of choice for all of them, acyclovir. So treatment for all of them, acyclovir. Next, we come to Epstein-Barr virus. This is the one that causes oral hairy leukoplakia. A question asked in the INI exam this time. Patient with HIV with this white plaque on the tongue that cannot be rubbed off. This is oral hairy leukoplakia. So if a patient with HIV comes with the white lesion, it can be OHL, it can be candidiasis. You have to try to rub it off. If it cannot be rubbed off, this is OHL. If it can be rubbed off, it is candidiasis. No special treatment is required. You start antiretroviral therapy, it self resolves. What other infection is caused by EBV? Can you tell me one more infection that's caused by Epstein-Barr virus? It has a triad of fever, sore throat, cervical lymphadenopathy. We see ampicillin rash in it. What is the name of the disease? Caused by Epstein-Barr virus. Infectious mononucleosis. So EBV also causes infectious mononucleosis, where we see ampicillin rash. Can you tell me one malignancy? There are multiple malignancies where EBV is involved, but one important malignancy. You may have read that in ENT. बताओ यार, बताओ. No, Kaposi sarcoma, not at all. It is not related to EBV. Yes, nasopharyngeal carcinoma, then Burkitt's lymphoma, other lymphomas, they can all be associated with EBV. Then we CMV. For CMV, just remember the name of the inclusion bodies. These are the Aula inclusion bodies with HHV6, roseola infantum. This will just be a red rash, no vesicles here. In the oral cavity, what do we see? Naga Yama spots. So where are Naga Yama spots seen? Roseola, also called as 6 for 6, sixth disease. So HHV6 causes roseola infantum, which is also called as sixth disease. Then HHV8, this is the one that causes Kaposi sarcoma. Please correct it. Kaposi sarcoma is associated with human herpes virus 8. This was the question asked in your July 24 exam. It is seen at what CD4 levels? At less than 200. When there is an infection that happens at CD4 levels of less than 200, this is called as an AIDS-defining illness. So Kaposi sarcoma is a cutaneous AIDS-defining illness. Since it's a vascular neoplasm, a vascular cancer, you see reddish purple lesions on the skin. It can also be present in the oral mucosa. So this is Kaposi. With this, only thing to remember is HHV8, CD4 levels, and reddish lesions. That's it. Then molluscum. They have not asked in a while, but this is like a question waiting to be asked. It is caused by molluscipox virus, which belongs to Poxviridi family. You see these typical pearly white papules with a central umbilication. How does central umbilication look? Like this. So there is a central dip. This looks more like the heart. Yes, it is more of a heart-shaped drawing. We are very far from Valentine's. I'm not drawing a heart here. I'm drawing a dome-shaped papule with a central umbilication. This is better. Hai? So this is a molluscum lesion. The sign that we see here, pseudocombus phenomena, inclusion bodies, Henderson-Peterson bodies. What kind of inclusion bodies are Henderson-Peterson bodies? Eosinophilic, intracytoplasmic. This is coming out to be a quick revision. I hope you all are following what we are discussing. Then we have HPV, which causes warts. When they are flat warts, they are plain, These are called as verruca plana. When they are raised with a rough verrucous surface, this is verruca vulgaris. So if you get this kind of a picture where the lesion has a rough verrucous surface, this is verruca vulgaris caused by human papilloma virus. This image was asked in the NEET PG 2020. So they can ask this image from you also. A lesion with a rough surface, this is verruca. A sign that we see here, pseudocombnus. So pseudocombnus is seen in molluscum. It is seen in viral warts or verruca. These are the two causes of pseudocombnus phenomena that you have to remember. Then hand, foot, mouth disease, most common cause, Coxsackie A16. Child presents with fever and vesicles, but those vesicles are present only on hand, foot, and the mouth. They are not present all over the body. The causative organism A16 can also be caused by enterovirus 71. Then we have parvovirus B19, very, very favorite. This was also there in your FMG July 24 exam. It was also there over here. What does parvovirus B19 cause? Aplastic crisis in patients with sickle cell anemia, fetal hydrops, and fifth disease. So fetal hydrops, fifth disease, and aplastic crisis. These are caused by parvovirus B19. गांधी जी का भक्त है, एक गाल पे थप्पड़ पड़ा, दूसरा गाल भी आके कर दिया. The child here presents with a slapped cheek appearance. So this is the typical red rash that we see on both the cheeks, slapped cheek appearance. Where is this seen? Parvovirus B19. Important to remember all these three because generally they ask you the question with this image, what is not caused by the causative organism? So you have to know these three to be able to answer that question. Parasitic infections, question asked in the July exam. A child with itchy lesions, itching increases in the night. Family members have it. What causes it? It is caused by the mite, Sarcoptes scabiei. They can also give you an image of the mite. This image will show you 4 pairs of legs, not 4 legs. It will be 4 pairs of legs. So a chotu motu mite with 4 pairs of legs. This is the scabies mite, causes scabies. Child will have itchy lesions, which are papules present most commonly in the finger webs. Itching is more in the night. Other family members will also have the disease. This is scabies. Then they ask you, what is the pathognomic lesion? Burrow. Where is the burrow present? Stratum corneum. What is the treatment of choice? 5% permethrin. What is oral drug used in scabies? Ivermectin. So simple points. Question asked recently, so it's a PYQ. Very important. This image of the scabies mite was a favorite image some time back. So this can again be asked. You should be able to identify this chotu motu mite with 4 pairs of legs. Then there are special forms. They can give image of infantile scabies. You see vesiculopustular lesions on the palms and soles of the child. So vesiculopustular lesions in palms and soles. This is infantile scabies. Plus, in infantile scabies, there always will be history of family members who have the disease because infant can't get the disease from anywhere outside, no? If they have to ask you infantile scabies, they will give you history of family members also suffering from the disease. Treatment of choice remains the same, permethrin 5%. Should we start with STDs? Is everyone thorough with what we have read till now? So with genital ulcers, the most common causes syphilis, chancroid, herpes, donovanosis, and LGV. A question asked on each of them in almost every exam. Now, like not each of them, one of them, but all of them have been asked in the last few years. Like LGV, they asked recently, chancroid, they asked in the previous exam, herpes, they keep asking, syphilis, they keep asking. Donovanosis, they have not asked till now, but you never know, they can ask. So now, when you get a question on genital ulcer, you have to see whether it is painless or it is painful. If it is painless, narrow down your options to syphilis, donovanosis. If it is painful, choose between chancroid and herpes. If it is a painless ulcer with painless lymph nodes, then this is syphilis. If it is a painless ulcer without any lymph nodes, it is donovanosis. So simple. First out of 4, you narrow to 2 options. In the 2 options, you see for lymphadenopathy, present syphilis, absent donovanosis. Now we come to the painful lesions. In chancroid, painful ulcers with painful suppurative lymph nodes, chancroid. Here it will be vesicles with painful lymph nodes. This is herpes. So if the word suppurative, that is pus, is mentioned, then it is chancroid. If vesicles are written, then it is herpes. If you understand these basic 4 lines that I have told you, you will be able to mark every question of genital ulcer. With primary syphilis, it will be a single well-defined painless indurated ulcer. They ask you, what is the next investigation? Dark ground microscopy. What is the treatment of choice? Benzathine, penicillin. Okay, so syphilis will be a single well-defined painless indurated ulcer. Indurated means the skin around and below the ulcer is firm. So a painless indurated ulcer with painless inguinal lymphadenopathy is syphilis. Next investigation, dark ground microscopy. Donovanosis will be red laddu. This will be a beefy red ulcer which bleeds on touch. So this will be a red laddu. Red laddu is donovanosis. What is the finding in this smear? Finding in the smear is Donovan bodies. What are Donovan bodies? These are bacteria which are intracellular. They stain on both the poles. They look like closed safety pin. So these are called as Donovan bodies. So red laddu with safety pin, donovanosis. There is no lymphadenopathy here, only genital ulcer which does not have lymph node. But one word that you have to remember here is pseudobubo. Where is pseudobubo seen? Pseudobubo is seen in donovanosis. Then we have chancroid. This was recently asked in your July 24 exam. Is there some mistake on this slide? I think there is some mistake on this slide. Who can correct it for me? I have done some mistake on this slide. Who is the Sherlock Holmes who is going to catch this mistake? Who is the Sherlock Holmes who is going to catch this mistake? Yes, very good. Very good. Very good. This is not the causative organism. You know, I've deliberately made this mistake so that you know what is the correct answer. Chancroid, very convenient to mark chlamydia, but no, the correct answer here is Haemophilus ducreyi. So the causative organism of chancroid is Haemophilus ducreyi. Painful ulcers with pus on the surface, with pus in the lymph node. So multiple painful ulcers which have a yellow surface with yellow pus in the painful lymph nodes, that is chancroid. This was the question asked in your July 23 exam. See, these are multiple ulcers. They can be present on the penis. They can be present on the scrotum. In versus herpes, I will just show you, will be just grouped vesicles present only at one site. While in chancroid, these ulcers can be distributed on different parts of the genitalia, depending where the bacteria has inoculated. Okay, so this is how you differentiate chancroid from herpes. Herpes will be just grouped vesicles at one place. Chancroid can be all over with painful suppurative lymph nodes. Gram stain shows railroad track appearance. Treatment of choice is azithromycin. While in herpes, I told you grouped vesicles with painful lymph nodes. These vesicles can rupture to form erosions. This is genital herpes. It has bilateral painful lymph nodes, but they don't have pus. They are not suppurative. The minute question says suppurative lymph nodes, go to chancroid. Now, what is the Zank smear showing? We have just seen it before also when we were doing viral infections. Zank smear shows multinucleate giant cells. Treatment of choice, acyclovir. Lymphogranuloma venereum, question asked in your January 24 exam. This is a cause of bubo. So the question asked, bubo is seen in LGV. Lymph nodes are painful, they are suppurative, they are full of pus, skin is red and swollen. What you see here is the groove sign of Greenblatt. Look at this image. This groove that you see, this is the groove sign of Greenblatt. Now, painful suppurative lymph nodes are bubo. So bubo was also seen in chancroid. Bubo is also seen in LGV. So how do you differentiate between the bubo of LGV and chancroid? How do you differentiate between the bubo of LGV and chancroid? Remember, in LGV, there is no genital ulcer when the patient comes with bubo. Patient only comes with bubo. So how do you differentiate? This is how you differentiate. In chancroid, the ulcer and the bubo are present at the same time. In LGV, patient only comes with the bubo. There is no genital ulcer. Plus, this bubo shows the groove sign of Greenblatt. So this is the difference between chancroidal bubo and LGV bubo. But if they ask you what causes bubo, this is going to be your better answer, because this presents only with bubo, no genital ulcer. That is why this was the answer in your exam, even though both chancroid and LGV were there in the option. But this is like the most characteristic cause of bubo. It does not have genital ulcer, only bubo. Now, if the patient takes treatment, good enough. If patient does not take treatment, complication of saxophone penis in the men and esthumine in the woman. Esthumine has been asked from you. Where is esthumine seen? This is seen in LGV. Well, I didn't tell you what causes LGV. Can anyone tell me? What causes LGV? This is the one which is caused by chlamydia trachomatis. This is the one which is caused by chlamydia trachomatis L1, L2, L3. Okay, it is not chancroid, it is LGV. Now, secondary syphilis, a very favorite of the FMG exam. A patient of primary syphilis takes treatment, good enough, does not take treatment, can develop secondary syphilis. In secondary syphilis, patient has rash all over the body, but it is not the rash that helps you in the diagnosis. It is this thing which helps you in the diagnosis. Coppery brown, scaly macules on the palms and soles. So if the question says coppery brown, scaly macules on the palms and soles, this is secondary syphilis. A question on this was also asked in the NEET PG 2024. So this is an important question. It can be asked in your exam. Coppery brown, scaly macules on the palms and soles. This is secondary syphilis. What happens in the genitalia? Condyloma lata. Lata means lata. These are flat lesions. So if you see them, these are flat gray colored lesions. Remember the color, because in the NEET PG24 exam, it was written as grayish lesions in the perianal area. So gray colored lesions in the genitalia, that is condyloma lata. Patchy non-scarring alopecia in the scalp, moth-eaten alopecia. So how did they give the exam, the NEET PG24 exam? They said patient has asymptomatic rash with gray lesions in the genitalia with scalp lesions as shown in the image. Image showed patchy non-scarring alopecia. What is the causative organism? You know, a lot of students in the NEET PG exam marked it as a fungal infection because they thought grayish lesions could be tinea. On the scalp, this could be tinea capitis. Okay, mark trichophyton. But this was not a fungal infection. See the whole picture. Rash on the body with rash in the groin with scalp hair loss. This is not a fungal infection. Tinea capitis only happens in children. It does not happen in adults. So this was not tinea. This was a case of secondary syphilis, and the correct answer for this was Treponema pallidum. So they gave an image of moth-eaten alopecia in the NEET PG exam, which was like a new image. But overall, the question is a very old PYQ. So new wine in an old bottle. That's how they ask you the old wine in new bottle. So this is old wine in a new bottle. They are just asking an old question in a newer way. Then we have tertiary syphilis, very favorite of the FMG exam. Skin pe to gamma hota hai, but they ask you the cardiovascular lesions. What part of the CVS is involved in tertiary syphilis? Look at this image. Tell me what part of the aorta. Okay, I'll give you the hint. What part of the aorta is involved in tertiary syphilis? What part? What part? Ascending aorta. Remember, it is ascending aorta, which is the most common involvement in tertiary syphilis. Treatment of choice: injection benzathine penicillin, single injection in primary secondary, 3 injections in tertiary syphilis. In neurosyphilis, treatment of choice is aqueous penicillin. So you have to remember these points: single injection, 3 injection, aqueous penicillin. If the patient is allergic to penicillin, you can give doxy, but if the pregnant patient is allergic, treatment of choice is desensitization. Treatment of choice is desensitization. Then we come to urethral discharge. Question asked as recent as January 24 in your exam. When they asked the question in the way they asked, I was like, what are they doing? What do they expect from the students? In the same exam, they asked this question. In the same exam, they asked you to differentiate between BL and LL based on SSS. You know what was the question asked? Which of the following requires male partner treatment? So which STD from the female can spread to the male? Candidiasis, bacterial vaginosis, herpes, trichomoniasis. Can anyone tell me what is the correct answer to this question? Which of these requires male partner treatment? Does not require तो बड़ा easy है. आप candida और bacterial vaginosis mark कर दो. But which does not require, तो simple है, which requires is trichomoniasis, because trichomoniasis can cause non-gonococcal urethritis. Herpes में हम treat करते हैं only if the patient is symptomatic. We don't treat an asymptomatic partner. Trichomoniasis we have to treat even if the partner is asymptomatic, because trichomoniasis can be asymptomatic in the form of non-gonococcal urethritis in the male. Now, gonococcal urethritis, question asked in NEET PG 24. A male with pus coming out of the urethra. What is the causative organism? Neisseria gonorrhoeae. So when you see pus coming out of the urethra, this is gonococcal urethritis. When you see just mucoid discharge, this is non-gonococcal urethritis. Non-gonococcal, most common cause, chlamydia trachomatis, but it can also be caused by these. So you need to know even the other causes of non-gonococcal urethritis. Then anogenital wart. Look at the number of reds here. This is how fond they are of anogenital warts. How fond. So this is anogenital warts, also called as condyloma acuminata. A for anogenital, A for acuminata. So anogenital warts are also called as condyloma acuminata. Like warts, they will also have a rough verrucous surface. So whether you see it on the penis, perianal area, or the vulva, look at the surface, it is going to be rough. Most common cause, HPV-6. Immunomodulator used, imicumod. Treatment in pregnancy, TCA, if TCA is not in the option, or if cryotherapy is not in the option, TCA. Now, do not confuse condyloma acuminata with condyloma lata. Don't confuse this. See, condyloma acuminata will be rough verrucous. Condyloma lata is going to be flat, grayish lesion seen in secondary syphilis. This is often a very big confusion in the exam. Lata, sleeping, soya Y, syphilis. Okay, so different ways of remembering that C lata will only be seen in syphilis. वो सोया हुआ है, वो syphilis में दिखेगा, वो लेटा हुआ है. ठीक है, so C lata, syphilis. A for acuminata, A for anogenital wart. Plus, very, very important, what will be the treatment in pregnancy? Cryotherapy or TCA. Vaginal discharge, again, they're very fond of vaginal discharge. I hope you have revised this in Obs Gynae. That makes my job easier. Most common cause, physiological. Most common, altered discharge, bacterial vaginosis. Itching with curdy white discharge, candidiasis. Greenish frothy discharge with the strawberry. What is the strawberry here? Strawberry is the cervix. So greenish frothy discharge with strawberry. This is trichomoniasis. Candida is white curdy discharge. Greenish jhag with strawberry. This is trichomoniasis. Bacterial vaginosis. Vaginal discharge कैसा होगा? Foul smelling watery discharge. So a typical foul smelling watery discharge, bacterial vaginosis. Vaginal pH more than 4.5, bacterial vaginosis. Whiff test positive, BV. Clue cells more than 20%, BV. Image of clue cells has been given in the INI multiple times. So these are vaginal squamps with Gardnerella chipko on their surface. This is bacterial vaginosis. You need 3 out of these 4 to make a diagnosis of bacterial vaginosis. Treatment of choice, metronidazole. Syndromic management, I am very sure you've done in community medicine. We can just revise it on the slide here. Yellow means pus, pus means PID. Red, base पे vesicles, that is herpes. So give red kit in herpes. This is a mnemonic told to me by a student. I am very strictly giving this as a disclaimer. Veg is green dot. So V for veg, V for vagina. This is green kit. Okay. Black is bubo. So give black kit in bubo. Okay. So if you remember these, That's more than half of your job to remember the syndromic management. I'm sure you can answer whatever comes in your exam if you remember this. So these are the 4. बाकी कुछ और आएगा तो rule out कर लेना. Now we come to the other half of dermatology. So what we have done till now is about 60% of the subject, but almost like 70% of the questions have come from what we have discussed till now. And now we come to papillosquamous disorders. Again, very favorite. Psoriasis. वो psoriasis नहीं पूछेंगे तो वो क्या पूछेंगे डर्मा में? Psoriasis तो उनको पूछना ही पूछना है ना? So psoriasis are red plaques with silvery white scaling. So these are red plaques with silvery white scaling. छीलोगे तो bleeding मिलेगी. This bleeding is called as Auspitz sign. So where is Auspitz sign? Seen in psoriasis. Red scaly plaques, ring of Warnoff, Auspitz sign. ये चीजें psoriasis के लिए बहुत जरूरी है कि आप याद रखो. Look at the beautiful silvery white scaling that you see here. Not so beautiful because in the exam you may not always get very beautiful images, but you have to know how to identify what the image is showing you. You are seeing well-defined plaques with silvery white scaling. This is psoriasis. I tell all the students all the time, do not rote learn the images. जो image मैं दिखा रही हूँ वो exam में कभी आएगी ही नहीं. सही बोल रही हूँ. This is a disclaimer that I'm giving you. जो मैं बता रही हूँ वो एग्जाम में नहीं आएगी. क्यों? क्योंकि एग्जामिनर तो वो फोटो देगा which he has seen the case in his OPD. So my image and the examiner's image is going to be different. It cannot be the same in any subject. It will not be the same because the images that they give will be their own patient's scans, their own patient's radiology, their patient's pathology. So you will not get the same image. You have to try to see what the image is showing you. So in this image, you see a red plaque with silvery white scaling. This is psoriasis. छिला हुआ दिख रहा है, बीच में पिन पॉइंट ब्लीडिंग है, Auspitz sign. कोबनस फिनोमेना, लीनियर लीजन्स दिखेंगे. दिस इज कोबनस फिनोमेना. कोबनस फिनोमेना इज छील दिया, जहां आपने छीला वहां पे नए निशान बन गए. लीजन्स एट साइट्स ऑफ ट्रोमा. दिस इज कोबनस फिनोमेना, ऑल्सो कॉल्ड एज आइसोमॉर्फिक फिनोमेना. ट्रू कोबनस होता है, स्यूडो कोबनस होता है. स्यूडो कोबनस वी रेड इन वायरस, मोलस्कम और वायरल वॉट्स. यहाँ पे हम पढ़ेंगे ट्रू कोबनस. ट्रू कोबनस में मेरा नाम याद रख लो, PLV. So true combness is PLV. PLV is PLV. Psoriasis, lichen planus, vitiligo. Okay, so wherever you see lesions in a line, that is showing Koebner's phenomena. Pseudokoebner's is not seen in herpes. Please don't think that pseudokoebner's only and only molluscum and viral warts. Okay, pseudokoebner's only in molluscum and viral warts. Guttate psoriasis asked in your July 24 exam. So very recent question, very important PYQ. Seen in a child with history of streptococcal sore throat. You get gatte. Rajasthani gatte hote hai na, small basin ki balls. So you see those small psoriatic lesions all over the body of the child. Guttate, अगर हम लैटिन भाषा में जाएं, although हमें लैटिन नहीं आती है, but हम लैटिन में जाएं तो guttate means raindrop. So when you see raindrop like lesions over the body, this is guttate psoriasis. History of streptococcal pharyngitis, treat with antibiotics. Where else is guttate lesion seen? Guttate hyperpigmentation. Where do you see guttate hyperpigmentation? Where do you see guttate hyperpigmentation? बताओ, जल्दी बताओ. बताओ. Guttate hyperpigmentation, you will see hyperkeratotic lesions on the palms and soles. Yes, very good. Guttate hyperpigmentation is seen in chronic arsenic poisoning. There are also arsenical keratosis on the palms and soles, risk of squamous cell carcinoma. Then we come to pustular psoriasis. पस्कुलर सोराइसिस में जो हिस्ट्री होगी, sudden withdrawal of systemic steroids means a patient who is a known case of psoriasis takes steroids, suddenly stops, develops pustules all over the body. This is pustular psoriasis. यहाँ पे आपको बस ड्रग ऑफ चॉइस याद रखना है, एसिट्रिटिन, प्लस इसका एक और नाम होता है, दैट नाम इज वॉन जुम्बुश डिसीज. सो पस्कुलर सोराइसिस इज ऑल्सो कॉल्ड एज वॉन जुम्बुश डिसीज. इसी का एक टाइप होता है विच इज पस्कुलर सोराइसिस ऑफ प्रेगनेंसी, ऑल्सो कॉल्ड एज इम्पेटाइगो हेर्पेटिफॉर्मिस. प्लीज डोंट मार्क इट एज अ पायोडर्मा. This is not impetigo. This is not herpes. It's a misnomer. This is pustular psoriasis of pregnancy. Only question that comes here is, what is the drug of choice? Don't mark antibiotics. This is not impetigo. Drug of choice here is steroids. This is pustular psoriasis of pregnancy. Erythrodermic image नहीं आती है, but ये options में आता है. तो जहां erythro है, erythro means red, dermis means skin. So more than 90% of the skin is red. That is called as erythrodermic psoriasis. Okay. Yes, only time steroids are given orally in psoriasis, that is impetigo herpetiformis. Histopathology, recent favorite. Remember the letter N. N, 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 and also N here. Kaise? What is parakeratosis? Presence of nucleus in stratum corneum. Whereas stratum corneum cells are not having any nucleus, but when you have nucleated cells in stratum corneum, parakeratosis, psoriasis is a very important reason of parakeratosis. Here N is neutrophils. Presence of neutrophilic abscesses in the stratum corneum, Monroe's microabscesses, seen in psoriasis. Here also N is neutrophils, neutrophils in stratum spinosum, cockroach pustules. And what is the N here? N here is nahi hai, negative. Negative means stratum granulosum chali gayi hai, hypogranulosis. So parakeratosis, Monroe's microabscesses, hypogranulosis, cockroach pustules. These are all features of psoriatic histopath. Very important. Asked in June 21, 2 questions on, two questions in the sense, one question was of histopath and the other question you had to rule out. So you anyway had to know that Monroe's is seen in psoriasis. Then what is happening to the nail in psoriasis? Pitting. There are pinpoint depressions on the nail surface. How do you differentiate the pitting of this from alopecia areata? Look at the type of pitting. Open your eyes. Look at the type of pitting. In alopecia areata, it was suffer, superficial, fine, regular pitting. यहाँ पे it is coarse, irregular, and deep pitting. See, in psoriasis, pitting is coarse, irregular, deep. In alopecia areata, fine, regular pitting. So that is how you differentiate between the pitting in psoriasis and the pitting in alopecia areata. Most common sign is pitting, but most specific sign is salmon patch. So most specific sign is salmon patch. This can be a question. You have to know the difference between most common and most specific. Psoriatic arthritis, they are very fond of asking. July 23, December 21, very, very important. A patient of psoriasis develops joint pain. The answer is psoriatic arthritis. So if psoriasis is not written, it is written that patient has had red scaly lesions, develops joint pain. Again, this is psoriatic arthritis. If it says this, then treatment of choice is methotrexate. Okay, so treatment of choice for a patient with psoriatic arthritis is methotrexate. Very, very important. Most common joint involved, नाखून के नीचे DIP. Radiology में, what is this finding in the radiology here on the slide? Who can tell me what is this radiology image showing? What deformity? What is the radiology here showing? Pencil in cup deformity. Next we come to lichen planus. Lichen planus is absolutely opposite of psoriasis. Psoriasis is not itchy. This is itchy. Then psoriasis is red. This is purple. Psoriasis on the extensor. This on the flexor. So whenever you see purple papules on the body, that is lichen planus. So these are purple papules on the body. These purple papules are also pruritic. Pruritic means itchy. Lichen planus is characteristically itchy. Then it shows a lacy reticulate stria on the surface. This lacy reticulate stria is called as Wickham's stria. And what is this image showing, this sign? Can anyone tell me what is this image showing? What is the image showing? Yes, this is showing Koebner's phenomena. Treatment, how do you decide the treatment? If it is less than 10% body surface area involved, you give topical treatments in the form of creams and lotions. If it is more than 10% BSA, we give oral treatments. Generally, it is steroids given here, steroids given here. So treatment depends upon the body surface area involved. Why is this important? Because in your exam in January 24, they gave a question on LP. A patient has purple pruritic lesions on the skin, on the wrist and the elbow. Some of these lesions have a linear configuration. It was hinting towards Koebner's. What is the treatment that will be given? Up, how do you decide the treatment? See, if the lesions are only on the wrist and the elbow, it is certainly less than 10%. So the correct answer was topical steroids. They had immunosuppressors and steroids both in the options. So topical steroids means you give in the form of cream and lotion. Cream and lotion तो आप तभी दोगे ना जब कम एरिया इन्वॉल्व है. पेशेंट पूरी बॉडी पे तो क्रीम्स नहीं लगा सकता रोज दिन में 2 बार. So less involvement, creams and lotions. More involvement, you give tablets. That was how you answered the question in the Jan 24 exam. Now, in LP histopath, LP again opposite of psoriasis, वहां पे granular layer कम थी, यहाँ पे granular layer ज़्यादा है. Then we see civet bodies. We see band-like inflammation. See, this is the band here. And we see sawtoothing of the rete. Sawtoothing means rete becomes pointed. यहाँ पे images नहीं आती हैं, but they can ask you in the form of all except. So hypergranulosis, civet bodies, interface dermatitis, sawtoothing. These are points that have been asked with respect to the histopath of LP. You should be knowing it. Now, apart from skin, LP can also affect the mucosa, nail, and the hair. When it affects the mucosa, you again see these patches with lacy reticulate stria on the surface. This is mucosal LP. Sometimes there can be an erosion in it. In that case, it is called as erosive oral LP. Risk of squamous cell carcinoma developing in erosive oral LP. But if you get it in the form of an image, lacy reticulate stria on the oral mucosa, this is mucosal LP. A wing-shaped fold of the nail fold, this is pterygium. So most specific sign in the nail is pterygium, causes permanent nail loss. Image of pterygium has been asked. Pterygium has been mentioned in multiple questions. Mucosal LP has been mentioned in multiple questions. You should be knowing it. Then violaceous patch with scarring alopecia, we have already discussed. This is hair lichen planus. Then we come to P. rosea. Very favorite of the INI in November 22 as well as May 23. They're very fond of P. rosea. P. rosea First lesion to appear on the body, mother's patch or the herald patch. So first lesion to appear on the body is mother's patch. Then multiple lesions come in a Christmas tree pattern. So this is the question that comes from here. Where is Christmas tree pattern seen? This is seen in P. rosea. Where is herald patch seen? P. rosea. So this you have to know. Plus, how does the typical lesion look like? Can anyone tell me? What is this kind of a scaling called as? What is this kind of a scaling called as? This scaling is dog का collar. लग रहा है ना dog के neck के जिसपे collar बंधा हुआ है? This is peripheral collarette of scaling. So peripheral collarette of scaling is seen in P. rosea. This is 2 times asked in INI. It can be asked in your exam also. Please remember, peripheral collarette of scaling is P. rosea. Then you see the Christmas tree pattern here. In dermatology, we need a lot of wishful thinking. So this wishful thinking shows you the Christmas tree in this image as well as here. So this is the Christmas tree appearance and the peripheral collarette of scaling. Next we come to bullous disorders. In bullous disorders, we have intraepidermal, which is pemphigus, subepidermal, which is pemphigoid. See, intraepidermal are superficial blisters. So S for superficial, S for of pemphigus. In subepidermal, the blisters are deep. So D of deep, D of pemphigoid. So intraepidermal is pemphigus, subepidermal is pemphigoid. What happens in pemphigus? Desmosomes are damaged. Desmosomes have proteins which are called as desmogleins. So you will read that the desmogleins are involved. What type of hypersensitivity? Type 2. What is happening? Cells are separating from each other. This is called as acantholysis. What do desmosomes do? Desmosomes join keratinocyte to keratinocyte. These keratinocytes are like this. They are squamous. So when they separate, when the antibodies kill the desmosomes, when the cells separate, they become round in shape. This is called as acantholysis. Acantho means cells of stratum spinosum. Lysis means separation. They are separating from each other. There are 2 important types of pemphigus that we need to remember. Pemphigus vulgaris, pemphigus foliaceus. F comes first, so it has the first desmoglein in it. This is desmoglein 1. V comes last. It has the last number 3 with 1. So remember, pemphigus foliaceus has desmoglein 1. Pemphigus vulgaris has desmoglein 1 and 3. Both of them have flaccid bullae with oral ulcers. Vulgaris without any mucosal involvement. Pemphigus foliaceus. See, basically, just see here. If the question says bulla, if the bulla is flaccid or the bulla can be tense. Flaccid means bulla wrinkled hai. Tense means pura pani ka bhara hua hai. If it says flaccid, this is pemphigus. If it says tense, this is bullous pemphigoid. Now, in order to differentiate between the types of pemphigus, look at the mucosa. If there is mucosal involvement, the answer is pemphigus vulgaris. If there is no mucosal involvement, the answer is pemphigus foliaceus. This is a basic way to approach a question that is talking about bullae. Flaccid, tense. Simple. Is this clear to everyone? Chalo, very good. So here we have flaccid bullae. See, these are the fus bullae, the flaccid bullae. This is pemphigus. If there is oral ulcers, it is pemphigus vulgaris. Nikolsky sign is positive here. क्या होता है, क्यों होता है, don't get into it. Just remember, Nikolsky sign is positive. Bulla spread is positive. They are positive in all types of pemphigus. Then we have Zank smear. What do we do in Zank smear? We do a Giemsa stain. The cells that we see are these round cells, which are called as acantholytic cells, also called as Zank cells. So these are acantholytic cells, also called as Zank cells. In the histopath, they will not give you image, so don't worry about it, but you just have to know what is seen. See, F comes first, so the split comes first. First means ekdam corneum ke niche. This will be a subcorneal split. V comes in the end, so the split is going to be deep. This deep split is a suprabasal split. Okay, so F comes first, desmoglein 1, split भी ऊपर आ जाती है, subcorneal split. V comes in the end, so this is desmoglein 3 and 1 with a suprabasal split and row of tombstone appearance. बस आपको नाम पता होना चाहिए. No MNGs are not seen in pemphigus. Please remember, when we make Zank smear in herpes shows MNGs. Zank smear in pemphigus shows acantholytic cells. So these are two uses of Zank smear, and these two uses show different findings. Okay, don't confuse between the findings of the Zank smear. DIF shows fishnet IgG in both. So you cannot differentiate between pemphigus vulgaris and pemphigus foliaceus on DIF. The findings are the same. The only way to differentiate between them is clinical features and histopath. Treatment, steroids, but remember the biologic that is used in pemphigus, rituximab. This is a CD20 inhibitor. This is a CD20 inhibitor. Rituximab is the biologic that is used in pemphigus. Can you also tell me a few more diseases where rituximab is used? You may have read this in medicine. Where else is rituximab used? It is used in the treatment of lymphomas. It is used in the treatment of rheumatoid arthritis. Very good. Correct answers. Then we come to the subepidermal disorders. Subepidermal में bullous pemphigoid. If you remember this line, that's it. You will answer all questions of bullous pemphigoid. Old patient with tense bullae with itching. Simple. जहाँ पे tense bulla आ गया, that is bullous pemphigoid. Itching आ गया, सोले पे सुहागा. Patient has to be an old patient, elderly patient. This is bullous pemphigoid. You see, this is the tense bulla. This is the balloon which is full of water. Full, pura tension mein hai ye. So this is the difference between the tense bulla and the fus or the flaccid bulla, which we saw in pemphigus. So this is bullous pemphigoid. Then we have linear IgA disease, also called as chronic bullous disease of childhood. The typical appearance that we see here is this one, which is the string of pearl appearance. So if you get a question on tense bulla in a child, this is linear IgA disease. Tense bulla in an elderly, this is bullous pemphigoid. And this linear IgA disease will also show us string of pearl appearance. Treatment of choice, Dapsone. यहाँ पे ये दोनों पूछते हैं. Correct? DH, very favorite. July 24 exam. Same question on DH in the FMG exam 24. Same question in the NEET PG 24 exam. So, like, same. They asked association of DH with celiac disease. So, if there is a patient with itchy papulovesicular lesions, papulovesicular means पहले स्किन पे थोड़ा सा solid raised papule होगा, उसके ऊपर vesicle होगा. This was written in your July 24 exam. I am not inventing this word. Like, we teach it, but they also gave it in your exam. So, itchy papulovesicular lesion with papillary tip abscesses with granular IgA at the basement membrane. This is celiac disease associated. This is dermatitis herpetiformis associated with celiac disease. Treatment of choice, Dapsone. They don't generally give image of dermatitis herpetiformis. This was a clinical one with a histopath image. In the histopath, you see the split is epidermis dermis. It is below the epidermis. So this is a subepidermal split with neutrophilic abscesses. अगर आपको ये भी नहीं पता था, आप क्वेश्चन में इची पैपुलोवेसिकुलर लीजन समझ लेते, आपका काम उसी से ही हो जाता. You did not even need to identify the histopath, if you had just understood what they are giving in the text. So don't be very worried looking at these images. Just remember what I'm telling you. Read the text. You should know your subject in order to answer it. वो one-liners और वो वाला time अब जा चुका है. So this is papillary tip neutrophilic abscesses, granular IgA at the basement membrane, treatment of choice Dapsone with a gluten-free diet. What is the antibody that you will do? In the FMG, they ask this way: itchy papulovesicular lesions with image of histopath. What is the GI condition that can be associated? Answer was celiac disease. In the NEET PG exam, how did they ask? A patient with itchy papulovesicular lesions with chronic diarrhea, what is the investigation that you are going to do? So investigation will be tissue transglutaminase. Okay, so the test that you will be doing is tissue transglutaminase. This is how they asked in the NEET exam. Then epidermolysis bullosa, the only thing, child with bulle at trauma-prone sites. If a child presents with bulle at trauma-prone sites, there may be a family history because this is a genetic disease. The answer is epidermolysis bullosa. Melasma, asked in your FMG July 24 exam. Female with bilateral symmetrical brown pigmentation on the face. Remember, this is always bilateral symmetrical. This is always bilateral symmetrical. Can be triggered with sunlight, pregnancy, or OCPs. When it happens in pregnancy, it is called as chloasma. B for brown, B for bilateral symmetrical. These are the two things that you have to remember in melasma. Then a child with, all of us have small black moles. Imagine a child being born with a big black mole. So basically, this is a big mole. Bada til. If you remember a bada til, present since birth, this is a congenital melanocytic nevus. Of course, it will be black. Some of you may be having moles with one hair coming out of it. Yes, you keep picking on that hair. Now, imagine a big black mole. So that big black mole is going to have multiple hair on it. So there is dark black skin with dark hair on it. This is a congenital melanocytic nevus. Risk of malignancy developing in the future. This was the question in the NEET PG 23 exam. They gave an image of the malignant melanoma. They asked what is a long-term risk in the patient. long-term risk in the patient is a malignant melanoma. Then same type ka lesion with bal, but not since birth, since puberty. This is Pecker's nevus. Okay, so same type of a lesion. It is more of brown with dark hair, but onset is puberty. This is Becker's nevus. So congenital melanocytic nevus comes from birth. It is black. Becker's nevus, puberty. This is brown. This is how you differentiate between a congenital melanocytic nevus and Becker's nevus. Mongolian spot, very important image. Blue colored lesions in a child at birth. Why is it blue in color? Because the melanocytes are present in the dermis. So what we have are dermal melanocytes. Whenever it is in the dermis, it is blue-gray in color. This is Mongolian spots. It is not a disease. It does not require any treatment. Goes away on its own. The nevus of Ota, why it is important? Because it was given in your exam as a DD of melasma. So this was there in the options. So how do you choose what is nevus of Ota and what is melasma? How do you choose? See, this is nevus of Ota and this is melasma here. Nevus of Ota is going to be unilateral. It will be blue-gray in color, and the eyes, that is the sclera, will also be involved. Melasma will always be bilateral. It will be brown and there is no eye involvement. This is how you differentiate between nevus of Ota and melasma. Simple. See, now come see the picture here. Nevus of Ota will be unilateral. It will be blue-gray, plus there will be involvement of the sclera. This generally happens in a dermatomal distribution, most common sites, V1 and V2. Now, similar kind of a blue-gray lesion on the back is nevus of Ito. Again, this has been given a DD in your exams. So you just need to know what is nevus of Ito. This is blue-gray nevus on the back, nevus of Ito. Then we come to the lesions of hypopigmentation. Albinism, genetic disease, autosomal recessive inheritance, defect in the tyrosinase enzyme. Baal bhi gaye, skin bhi gaya, eyes bhi gayi. So hair is white, skin is white, iris is blue. This is albinism. There is increased risk of all types of skin cancers in these patients. So they require strict sun protection. This is albinism. Then we have vitiligo. In vitiligo, remember, this is not genetic. This is an autoimmune disease where the melanocytes are killed. Because they are killed, there are white patches. So here the patient presents with white macules on the body. What is this sign showing? This sign is showing Koebner's phenomena. So PLV. Yeah, in albinism, skin biopsy will show normal melanocytes, no melanin. Very good. See, यहाँ पे melanocytes are present, but they are not able to make melanin. So melanocytes are present in albinism, but they cannot make melanin. In vitiligo, ना रहेगा बांस, ना बजेगी बांसुरी. No melanocytes, no melanin. So that is the difference between albinism and vitiligo. There is this special type of vitiligo which is called as segmental vitiligo. This is a very favorite of the INI. This was asked in INI May 24 also. What is segmental vitiligo? Generally seen in children, unilateral along the dermatomes. So this is always unilateral. This is along the dermatomes, and this is the most stable type of vitiligo. Plus, the hair in the lesion are white. This is called as leukotrichia. So hair in the vitiligo lesion are white. This is called as leukotrichia. Then we have nevus depigmentosus. This is also a white patch, but it is present at birth. See, you look at segmental vitiligo. This is also unilateral. This is also white. Look at nevus depigmentosus. This is also unilateral. This is also white. So how do you differentiate? This is present since birth. Segmental vitiligo comes later in childhood or in adults. Okay, so this is a nevus. It is present since birth. Plus, the question may mention that the size increases with increase in age. This is nevus depigmentosus. Plus, there is no leukotrichia. That means the hair in the lesion are not white. Then we have piebaldism and hypomelanosis of Vito. These are generally the options in your question on segmental vitiligo. So you have to know how to rule them out. Piebaldism, Indira Gandhi. White lut. Or maybe remember the horses that you may have seen on racing tracks. असली में नहीं गए हो, मूवीज में तो देखे होंगे वो हॉर्सेस के वाइट टिक के. मैं भी नहीं गई हूँ, बाय द वे. आई आल्सो नेवर गॉन फॉर हॉर्स रेसिंग. सो you have the white tikka and the horse has white flowing hair which are flowing when the horse is running. So that is piebaldism. This is seen on the forehead, white patch on the forehead plus hair above it are white. This is piebaldism. Hypomelanosis of Ito, I told you, is one of the lesions that happens in a Blaschkoid pattern. So you get white lines in Blaschkoid pattern. This is hypomelanosis. Hypo means reduced, melanosis means pigment. So what you get are hypopigmented lines in Blaschkoid pattern. Please don't confuse this with nevus of Ito. Nevus of Ito was blue-gray only on the back. Okay, so nevus of Ito is different from hypomelanosis of Ito. They are not the same. Then chemical leukoderma. Some chemical causes depigmentation. This is chemical leukoderma. Most commonly they ask you a question on bindi leukoderma. B for bindi, B for the PTBP. ये तो erase ही हो गया. So B for bindi, B for BTBP. I know it erases. I just wanted to mark the B for you. So B for bindi, B for PTBP, para-tertiary butyl phenol. If you get it in the image where the lady applies the bindi, there instead of red bindi, she has a white bindi. So this is chemical leukoderma. In the eczemas, allergic contact dermatitis is a delayed type 4 reaction. Most common cause is parthenium. Most common metal is nickel. So where there is a ring, a chain or a belt buckle, this is all metal. Metal mein the reason is nickel. Cement, C for cement, C for chromate. So cement dermatitis happens due to potassium dichromate. D for dye, D for PPD. So cement dermatitis, no, kumkum has no English word. We call it as kumkum dermatitis only. The cause is different though. It has more of heavy metals which cause the reaction in kumkum dermatitis. So C for cement, C for potassium dichromate, D for dye, D for paraphenylene diamine. This question, NEET PG 23, you should know. Then airborne contact dermatitis will be a farmer with an itchy rash. So farmer with itchy rash, this is airborne contact dermatitis. The cause is Parthenium. How do you diagnose all contact dermatitis? Patch test. So remember, how do you diagnose? Whether it is asking for nickel dermatitis, whether it is asking for airborne contact dermatitis, all contact allergic dermatitis, diagnosis is patch test. Reading 48 hours, 96 hours. Atopic dermatitis will generally be seen in a child with itchy rash. So atopic dermatitis will be a child with an itchy rash, deficiency of filaggrin. When the question comes, question will generally come like this. Baby with itchy rash with asthma in the mother. So when this kind of a clinical scenario comes, they are talking about atopic dermatitis. Why? Because personal or family history of atopic disease may be present. Most commonly, they give this kind of a clinical picture. So mother or father किसी में asthma कर देंगे. This is atopic dermatitis, and it actually happens in the clinics also. You know, when you will go to the OPDs, you will see most of the patients with atopic dermatitis have asthma or rhinitis in their family or even in the patient itself. Then the question comes here, childhood AD, adult AD, which is the most common flexural site? Cubital fossa. This question has been asked in your exam. Most common site for childhood AD, cubital fossa. All the patients come and show their arms like this. This is the rash. So the rash is on the cubital fossa. Then in the eye, this image has been asked in your exam. Denim organ folds. These are extra lines under the eyes. The minute a patient comes and sits in front of us, I see the denim organ folds. I don't even have to ask the patient if they are atopic. This is like a marker of seen in almost all atopic diseases. Denim organ folds. Loss of eyebrows in the outer 1/3, Hertog sign. When this loss of eyebrows happens in leprosy, this is called as madarosis. When it happens in atopic dermatitis, it is called as Hertog sign. Then we come to seborrheic dermatitis. Seborrheic dermatitis, if they want you to diagnose, they will tell you patient has yellow greasy scaling. The fungus that is involved, Malassezia furfur. So if the question says patient has yellow greasy scaling, sebderm causative fungus, Malassezia furfur. They can give this image, a small baby with yellow greasy scales on the scalp. This is cradle cap. This is common after birth. Self-resolves. Drug reactions बहुत simple है. Drug reactions. Patient has single lesion. It is round, purple, surrounded by redness. There is history of it repeating. This is a fixed drug eruption. If it is a target lesion present on hands, feet, oral mucosa, this is erythema multiforme. If there is full body involved, peeling of skin, oral ulcers, this is toxic epidermal necrolysis. This is how you have to approach a question of drug reactions. Is this clear to everyone? Cradle cap is caused by malassezia. Dermatophytes don't cause cradle cap. Dermatophytes cause tinea capitis. So these are the drug reactions. Now we come to fixed drug eruption. See, a purple rash with surrounding redness. It is round in color. There is a history that every time patient takes the drug, he develops the rash. This is fixed drug eruption. Most common drugs: NSAIDs, Septran or cotrimoxazole. Then erythema multiforme, target lesion, 3 rings. So wherever you read the word target lesion, that is erythema multiforme. Plus one more question comes from here. Most common infectious cause, herpes. Infections by herpes simplex virus 1. This is erythema multiforme. And then we have toxic epidermal necrolysis. Most common drugs, antibiotics, anti-epileptics. Surface area less than 10%, SJS. More than 30%, toxic epidermal necrolysis. So see, you will see skin peeling in sheets plus oral ulcers. So skin peeling in sheets with oral ulcers, this is toxic epidermal necrolysis. This can come as an image. You should know this image. 10. NF type 1, very favorite of the exam, asked in June 22, asked in July 24. What they asked? They have asked inheritance twice. Inheritance is autosomal dominant. These are cafe au lait macules. Then this is axillary freckling. These are the neurofibromas, which can happen over the body. And in the bigger lesions, which are the plexiform neurofibromas, we get bag of worm on palpation. What do you see in the eyes? In the eyes, we see leash nodules. These are pigmented hamartomas. They cannot be seen with naked eye. You need to see them with slit lamp examination. They do not affect the vision. That is important to remember with leash nodules. Another finding in the eye, optic glioma. If a patient of NF comes with fluctuating high blood pressures, you may have read this in pathology. What do you have to suspect? Fluctuating high blood pressures in a patient with neurofibromatosis. Pheochromocytoma. Then what is the characteristic of NF2? Can anyone tell me what is the most characteristic feature of neurofibromatosis type 2? Bilateral acoustic schwannomas or neuromas. This is the most characteristic feature of NF2. Then we come to tuberous sclerosis, also called as Bonwell's disease, autosomal dominant inheritance, Vogt triad, lower, epilepsy, low intelligence, adenoma, sebaceum. All of these are questions that they ask from tuberous sclerosis, including the synonym. You know, if you look at the older questions, this is a very favorite one. Bonwell's disease, also called as tuberous sclerosis. Then, earliest feature, ash leaf macules, which are hypomelanotic macules. You can better see them with Wood's lamp. Then Keenan's tumors. These are soft tissue tumors around the nail. Lesions on the face, around the nose, adenoma, sebaceum. So ash leaf macules, adenoma, sebaceum, Keenan's tumors. These are 3 important cutaneous findings that you have to remember. Incontinentia pigmenti, X-dominant inheritance. And what are these lines? What is the distribution? Can anyone tell me, looking at this picture, what lines are these? Tell me, what are these lines? Yes, very good. See the spiral on the scalp? When you see the spiral on the scalp, you have to know that these are Blaschkold lines. And since this is X-dominant inheritance, patient is always going to be a female. There is a midline demarcation, and as if somebody has drawn Blaschkold lines on her body with a black marker. So that is incontinentia pigmenti. Then xeroderma pigmentosum, as recent as July 24 exam, autosomal recessive inheritance, nucleotide excision repair defect, patient has photosensitivity, freckles, increased risk of all types of skin cancers. So patient with photosensitivity, freckles, increased risk of all skin cancers. This is xeroderma pigmentosum. They ask the inheritance, they ask the defect. Peutz-Jeghers syndrome, colonic polyps with lentigenes on the oral mucosa. This is Peutz-Jeghers syndrome. Then urticaria, the most characteristic lesion that we see in urticaria are the wheals. The type of hypersensitivity, type 1, mediator histamine. The primary lesion of all urticarias is wheal. What is symptomatic dermographism? When you stroke on the skin with a blunt object, wheals develop in a similar distribution. So dermo means skin, graphism means writing, as if you're writing on the skin and that is becoming a wheal. So this is symptomatic dermographism. Then if a patient develops urticarial wheals on exercise or going out in sun, this is cholinergic urticaria. Image is not important here. Image is always going to show a wheal. You just have to remember cholinergic urticaria is urticaria developing on going out in sun. Urticaria pigmentosa is a type of cutaneous mastocytosis. The sign that we see here positive is Darier's sign. So the only question that comes here, where is Darier's sign seen? That is seen in urticaria pigmentosa. In angioedema, remember it is non-pitting edema. It can be caused by ACE inhibitors, mediator, bradykinin. So with angioedema, the drug that causes it, ACE inhibitors, mediator, bradykinin. Then hereditary angioedema, also called as Quincke's disease. You have read this in pathology also. Urodeficiency of C1 esterase inhibitor. Remember, it is not C1 esterase deficiency. It is C1 esterase inhibitor deficiency. Autosomal dominant inheritance. If you get this fula hua muh, as if madhumakki kaati hai, this is angioedema. Seborrheic keratosis, they don't generally ask, but just remember laser Trillard sign, gastric adenocarcinoma, rapid increase in septae all over the body, gastric adenocarcinoma. Then syringomas is in the options. These are tumors of the sweat glands around the eyes. So syringoma will only be seen around the eyes. Keratoacanthoma, they don't ask. BCC, they will always asking. Look at the number of red boxes here. Very, very important. Most common skin cancer. Locally aggressive. No metastasis. Typical lesion. A skin-colored lesion with telangiectasias with this margin. What is this classic margin? Classic margin are the rolled up borders. So remember, in basal cell carcinoma, we classically see rolled up borders. This was in fact your question in the Jan 24 exam. So what is rolled up border? As if you're squeezing a towel or you're eating a croissant in a bakery. That's a rolled up border. If this BCC ulcerates, this is called as rodent ulcer. Ulcerative BCC is called as rodent ulcer. So you see the ulcer here, but also you see these rolled up borders which help you identify that this is a BCC. The type of surgery that we do in BCC, most micrographic surgery. Marginal ulcer, question as recent as July 23. This is a SCC which develops in a burn scar. So if you get this as an image, you see that the surrounding skin has a scar, and in the center of the scar, you get a chronic ulcer. Cutaneous horn, when this was asked in August 2020, I was beyond shocked. How can they ask this to FMG students? But they have. See, this is a cutaneous horn. On the base of this cutaneous horn, the cancer that is there is squamous cell carcinoma. In fact, this was the question that they had asked. A patient presents with a cutaneous horn as shown in the image. What malignancy it is associated with? This is squamous cell carcinoma. Then malignant melanoma also, black cancer. So this is basically a black cancer. So when it is black and it is a cancer, it is malignant melanoma. In this, how do you identify? Can anyone tell me how in this image you identify? You do the ABCDE. You see that the lesion has become asymmetrical with uneven borders, with variable colors. So this is the ABCDE assessment, which helps you identify if this is a malignant melanoma. See, asymmetrical lesion with uneven borders, variable colors, increase in diameter, increasing changes. This is the ABCDE assessment. In most of your exam questions, this assessment helps you identify a case of melanoma. Most important is multiple colors and uneven borders. If you see these two things, you are dealing with a melanoma. With mycosis fungoides, the only question that you have to remember is Poitras abscess. Where a Poitras abscess is seen, this is seen in mycosis fungoides. What is mycosis fungoides? Cutaneous T-cell lymphoma. Sézary syndrome, where is this seen? This is also seen in association with mycosis fungoides. In the paraneoplastic phenomena, these are the important ones that are asked. Acanthosis nigricans with gastric cancer, necrolytic migratory erythema with glucagonoma, migratory thrombophlebitis with CA pancreas. This is also called as Trujillo syndrome. So this is also called as Trujillo syndrome. Acanthosis nigricans, very important. Velvety hyperpigmentation on the neck. This is acanthosis nigricans. The associations that we have to remember: diabetes, obesity, metabolic syndrome, nicotinic acid, gastric cancer. Very important. Mostly, what are the first line telling you? The first line is telling you patients with insulin resistance. So acanthosis nigricans is associated with insulin resistance. This image has also been asked in your exam. These are skin tags, also called as acrocordons. You may have seen that in people around you. These are skin tags. Then dermatomyositis. They just ask, where is heliotrope rash and Gottron's papule seen? This is seen in dermatomyositis. Patient will have skin rash with bilateral proximal myopathy. So skin rash with photosensitivity with bilateral proximal myopathy. If you see it on the face, this is heliotrope rash. You see it on the metacarpophalangeal joints and the interphalangeal joints. Violaceous papules. These are Cotron's papules. In pellagra, look at the number of red boxes here. This is as fond as they are of pellagra. Very, very important. Who are at risk of pellagra? Chronic alcoholics, maize eaters, and people who are taking ATT, isoniazide. So these are people who are at risk of developing pellagra. Deficiency of niacin or vitamin B3, diarrhea, dermatitis, dementia. What we see on the neck is a photosensitive rash. This is called as Casel's necklace. Very, very, very important. Pellagra. Then acrodermatitis and enteropathica also, only as important. Deficiency of zinc, autosomal recessive inheritance, triad of DAD, diarrhea, alopecia, dermatitis. With, in your questions, it mentioned there is poor wound healing. So diarrhea, alopecia, dermatitis with poor wound healing. This is acrodermatitis and enteropathica. Image that you will get will be an erosive rash on the face or the groin of the child. Phrenoderma, not yet asked in the FMGE exam. It is more of a NEET PG favorite, but you never know. You can be asked phrenoderma also. This is a frog-like skin. There are dry follicular papules on the elbows and the knees. Happens due to deficiency of vitamin A, B, E, K. These are all fat-soluble. B is not fat-soluble. So A, B, E, K, and essential fatty acids. This is toad skin or phrenoderma. Then, if you generally get X-linked recessive ichthyosis, will always be a boy patient. See, X dominant is always a female. X recessive patient is always a boy. Boy with undescended testes, with dark black scales. This is X recessive ichthyosis. Then you can get an image of colloidon baby versus a harlequin ichthyosis. C for colloidon, C for cellophane. So this is a baby wrapped in a cellophane sheet. This is a colloidon baby. And harlequin babies have a white, thick skin. See, harlequin नाम से तो ऐसा लगता है ना जैसे harlequin fighters होते हैं. So this is a baby as if he's wearing fighter clothes. बड़ी सी वो नाइट की तरह शाइनिंग आर्मर वाइट पहनी हुई है, उसके ऊपर डिजाइन है. So this is a harlequin ichthyosis. How do you have to differentiate? Harlequin ichthyosis will be like a fighter, although the actual meaning of harlequin are jokers. They wore clothes with fancy prints on it. But, well, this child does not look like a harlequin that way, so we'll call him a fighter. So that's a fighter with a thick skin. Colloidon is a cellophane sheet. Neutrophilic dermatosis, generally seen in patients suffering from inflammatory bowel disease. Agar red laddu hai, so this is sweet syndrome. You see red lesions on the body. Agar gangrene ho raha hai, ulcer ban raha hai, then this is pyoderma gangrenosum. You've gotten a question on pyoderma gangrenosum in your August exam. So a patient of inflammatory bowel disease with a painful ulcer with violaceous margins. So patient of inflammatory bowel disease with the painful ulcer with violaceous margins. This is pyoderma gangrenosum. Treatment of choice for both is steroids. Treatment of choice for both is steroids. Cutis marmorata, you must have read this in peds also. It's a normal finding that you see in newborns. When they're exposed to cold, you get this kind of marbling on the skin. When you make them wear clothes, it disappears. This is physiological. It is not a disease. Cutis marmorata. Now, these are the important ones that you have to know how to differentiate. A port wine stain from a salmon patch, from a infantile hemangioma. Port wine stain will always be unilateral. It will be in a dermatomal distribution. V1, V2 division of the trigeminal nerve. Plus, it is present since birth and it is non-blanchable. Salmon patch is not unilateral. It is actually in the midline. See, this is in the midline and this is blanchable. It disappears on its own. It does not require any treatment. Infantile hemangioma comes after birth. It is not present at birth. This is present at birth, this is present at birth, but this comes after birth. This is also a red laddu in a baby. So a red laddu in a baby is infantile hemangioma. A syndrome associated with Portwine stain, Sturge-Weber syndrome, ipsilateral Portwine stain, ipsilateral glaucoma, same side tram tract calcifications, but seizures on the other side. So that is Sturge-Weber syndrome. Last, this was a question in your July exam also. Hinot-Schoenlin purpura, it has been asked in 2019, 2018. At that time, it was a very favorite question, also called as IgA vasculitis. Child with palpable purpura, especially on the dependent parts of the body, the legs and the buttock, abdominal pain, melena, glomerulonephritis, that is cola-colored urine, hematuria, and joint pains. So that is Hinot-Schoenlin purpura. The antibody that is deposited in the kidneys as well as the skin is IgA. So this is also called as IgA vasculitis. With this, we finish our dermatology rapid revision. I hope all of you have found this session useful. I have tried to cover almost everything that is important in derma. Basically, the entire derma is important. छोटा सा subject है, 14-15 topics हैं, 10 questions पूछेंगे, तो there is like such a high chance of every topic coming. So, if you are able to revise this at least 2 to 3 times before your exam, you will be more than happy with the questions that come because you are going to score 10 on 10 in all those questions. All the best for your exam. Study as much as you can. Don't rote learn images. Try to understand the images. Read the text description of the image, then look at the image, so that you're able to read that and see that also. Okay. Thank you. Good night. Any doubts, you can Instagram me on Dr. Pallavi Dermatology on Instagram. You can DM. I try to answer as many doubts as I can. Otherwise, you can also note that in the comments. We'll be happy to answer. Thank you. Good night.
Recording stopped.